To introduce our first panel of the day. As I mentioned, we're going to be starting hearing from on 3 different sessions. The first of our talks is going to focus on e-cigarette, cigarette, or cannabis use and mental health conditions among college students in the United States before and during the COVID-19 pandemic. We'll follow that conversation up with a presentation on college student dual and polysubstance use patterns and mental health outcomes. And then I'll close the session this morning by just sharing what are some different factors that are impacting changes in student tobacco and marijuana use. So with that, I am going to stop sharing and introduce to you all Wang. And Nan, I'm very grateful that Nan, you can be here today and share. Nan is a postdoc student at UC Davis and will be sharing some new research that her and colleagues have done. And I just want to note with this panel, please make sure if you have any questions for the speaker, we're planning on having questions for each of the speakers right after their session. So feel free to just drop those in the chat box and I will share those with Nan after she presents. Thank you so much. And Nan, you can go ahead and share your screen and slides.
Okay. Can you see my screen?
Yep, looks great.
Okay, thanks Kim for the kind introduction. Yeah, again, my name is Wang, and I'm a second-year PhD student at UC Davis. And today my topic is focused on the relationship between cigarette, e-cigarette, or cannabis use and the mental health conditions among college students in the whole United States. And we also compare this association, if this association changed before and during the COVID-19 pandemic. And this paper I collaborated with Dr. Melanie Dove and Dr. Eliza Tang, and they helped me a lot. And the results from this study we were presented at the 2023 Society for Research on Tobacco and Nicotine and Tobacco Conference. Okay, let's move on to the background. Why do we focus on young adult substance use? Because among young adults, the prevalence of cannabis and e-cigarette use increased dramatically, especially recent year. And even if the prevalence of cigarettes decreased, yeah, we did a great job, but there is still around 750,000 young adults initiated smoking every year. And additionally, there is a growing trend among young adults to use these 3 products together. So we focus on the substance use among young adults. Why do we focus on college students? Nearly half of the young adults attend college in 2020, and the college is an important period when many individuals begin experimenting with substances and developing long-term habits. Additionally, college students face lots of the stressors as the challenges which may contribute to their mental health. Thus, college is a very important environment for addressing tobacco and cannabis use, as well as mental health issues. Why do we focus on mental health? Because the COVID-19 pandemic shutdown in spring 2021 has led to an increase in mental health conditions. And according to the previous study, it shows that e-cigarette, cigarette, or cannabis users were more likely to suffer from mental health issues compared to the non-users. However, little is known about how this association between substance use and mental health conditions were impacted during the COVID-19. In the spring 2020 and the fall 2020, 2 national studies among college students noted that tobacco or cannabis use was associated with mental health condition. However, little is known about this association between product use and the mental health conditions during the spring 2021 when students plan to return to school. So based on the research gap and the research question, we raised our research question. And this study is focused on if cigarette, e-cigarette, or cannabis users have a higher risk of suffering from mental health conditions during the COVID-19 compared to before the COVID-19. After introducing the research question, let's move on to our methods. In this study, we use a public data set, the data named American College Health Association's National College Health Assessment 3, also known as ACHA-NACHA 3. And the product used in this study were including current cigarette use, current e-cigarette use, and current cannabis use. And let's to see how to define each of the current users in this study. According to the ACHA-NACHA questionnaire, the current use and the tobacco product use were estimated by the two questions. The question one is, in your life, which of the following substances have you ever used? After respondents answered they used tobacco or nicotine products, they were defined as the tobacco user. The second question asked, in the past 3 months, how often have you used the substance you mentioned? If their answer is equal or higher than past months, like they used this product in the past months, they were defined as the current tobacco user. And according to the tobacco types, if they answered the cigarette, they were defined as current cigarette user. If they ask e-cigarette of the tobacco type, they were defined as current e-cigarette user. The total percent of the other current tobacco products were used was less than 2%. Due to this sample size is very small, so we didn't include in the other tobacco product in this study. And for the current cannabis user was similar assessed as the current tobacco.
Oh, Nan, you just got muted.
Can you hear me now?
Yeah.
Okay, sorry. The current cannabis user was similar assessed as current tobacco users. If the participants answered cannabis in the question 1, and then answered they used the cannabis in the past months, and then they were defined as the current cannabis users. The mental health condition in this study, including serious psychological distress, anxiety, and depression. How could we define these 3 mental health conditions? Let's move deeper to the questionnaire. The serious psychological distress is defined by the Kessler 3. There are 6 questions asking if you feel nervous, hopeless, restless, depression, that everything was effort or worthless. And each question have a different answer, and each answer had related to the different score. Then we ended all the score. If the score is higher or equal than 13, they were defined as serious psychological distress. And anxiety and depression are assessed using the following question. Have you ever been diagnosed by a healthcare or mental health professionals with any of the following ongoing or chronic conditions? If the respondents choose anxiety, they were defined as students with anxiety. If they answer depression, they were defined as students with depression. Here are other factors were considered in this study, including socio-demographic characteristics, including age, gender, race, and ethnicity, college-related variables, including academic performance, public or private school, campus size, and region, substance use, including binge drinking, and to reflect before and during the COVID-19 pandemic, survey periods including fall 2019, which was defined as before COVID, and the spring 2020, fall 2020, as well as spring 2021. The last 3 periods were defined as during the COVID-19. After knowing the methods, let's move on to the results. This figure shows the prevalence of the product use from fall 2019 to the spring 2020, and we can see overall then no big changes in the cannabis, e-cigarette, and the cigarette use over time from fall 2019 to spring 2021. You may ask why there is lower points here for the cannabis in the fall 2020. This is due to the study has a limitation because the lockdown in the fall 2020, in this study period, the student sample size is very, very low. So this sample size might not be super representative. Yeah. And after knowing the prevalence of the product use, let's look at the overall prevalence of the mental health. And we find in this fall study period, we find increased in the serious psychological distress, anxiety, and depression from fall 2019 to spring 2021. After knowing the overall trend of the mental health condition and the substance use, what is the relationship between these two things? And we found, compared to the non-e-cigarette user, we found e-cigarette user will have like the 1.5 to 2 times risk of the mental health conditions. Similar, when we compared to the non-cigarette users, we found cigarette users, they were 1.6 to 2 times higher risk of suffering from mental health condition. For the cannabis, it's similar. Compared to the non-cannabis user, we found current cannabis user were 1.6 to 2.2 times risk to suffer from mental health conditions. And as I mentioned before, there are more and more people, they will use these products, 3 products I mentioned, e-cigarette, cigarette, and cannabis together. And then let's look at what the association between single, dual, triple use of the mental health condition. The single use is defined as if they use any of one of these 3 products, they will define it as single use. If they use any of these 3 products, we will define it as dual use. If they use these 3 products concurrently, they will define it as the triple use. And then we found the more tobacco or cannabis product when you use, and the more likely you are to suffer from mental health. Let's move on how the changes of the association, if the association between substance use and the mental health changes during the COVID-19 compared to the before the COVID-19. And I will make a very brief introduction of the meaning of the odds ratio. Odds ratio is a statistical method to know how many times substance users are more likely to experience mental health problems compared to non-users. And overall, we found our odds ratio is between 1.5 to 2 in these 3 figures. And we found our odds ratio, which means that compared to the non-users, substance users were 1.5 to 2.5 times to suffer from mental health conditions. When we look at each odds ratio in the different study periods, we found the association between current product use and the mental health was strongest in the fall 2020. Okay, let's move on to the discussion. We found the US college students have an increasing burden of the mental health conditions that have significant associations with using tobacco or cannabis product. And the more tobacco or cannabis product you use, the more likely you are to suffer from mental health conditions. These findings are very important to consider for supporting students and the college that have smoke and tobacco-free college policy, especially when college continue more in-person teaching and activities. The treatment resources may be prominent at students' health, including mental health service, remote tobacco cessation service, or with state quit line for tobacco and cannabis. There are several limitations in this study. The first of all, the study is cross-sectional or an observational study, so we cannot get any causality. Second, the measurements in Ultra are self-reported, which may be subjected to recall bias or social desirability bias. Third, the fall study waves had the latest number of the respondents in fall 2020 during the COVID-19 outbreak, and overall, the response rate of the fall study periods are lower than 15%. Last, Ultra does not include the duration of the product use and how cannabis is being used. Thanks for your attention. I'd like to hear your thoughts. So please feel free to ask me any question or share any comments.
Thank you so much, Nan, for sharing. That was excellent information. And again, I think it's nice to see this lens of not only looking at the tobacco use, also the marijuana use, but how it is all connected to student mental health. So we do have a few minutes for questions. If you have a question for Nan, you can either drop it in the chat box, and you are also able to unmute yourself if you'd like to ask questions audibly.
I have a question. This is Stephanie Lake from UC Davis. I'm just wondering, Nan, this was a great presentation. Thank you. How many was the like? How many different colleges did you look at in this particular sample? Because that I missed that at the beginning. Or what? Like, how many Nacha surveys did you look at?
You mean how many?
Like how many different colleges did you look at?
Oh, I think Nacha is a university self-selected the different study periods. They have the different number. I think the number between from 2019 to spring 2020, the number of the colleges between 15.6 to 112. Yeah, I think for.
So did you look at the national, or did you ask each individual? Because like we do it here at UC Davis. So I have the executive summary for UC Davis. So did you just look at the national one, or did you ask individual colleges to give you their summary? That's
I think it's, thanks for your question. I think it's a national one.
Okay,
yeah,
national. Got it.
Yeah.
Okay.
Thank you.
Are there any additional questions for Nan? Okay, I am seeing none. So thank you so much, Nan, again for this talk. And I am now going to turn it over to Dr. Yang and Dr. Jacobs to share with us, looking specifically at dual and poly use of substances, as well as looking at gender and race and ethnicity. Thank you so much.
Thank you, Kim, so much, and thank you everyone for having us. I'd like to acknowledge my co-presenter today, Dr. Wura Jacobs, and our collaborator, Camelia Louie, who'll be speaking tomorrow for the work that we've been doing. So today, our presentation will have four main areas. We'll give a little bit of study background, discuss some of our methods. The bulk of our presentation will be presented by Dr. Jacobs, will be the results. We'll talk about a summary of the results and some next steps as discussion points. So much as Nan talked about and covered in the previous presentation, we wanted to sort of look at tobacco use and other substance use among young adults and college students. So data from the Monitoring the Future panel study from collected in 2021 shows that rates of cigarette use and vaping of nicotine and cannabis, as well as any cannabis use, they're all relatively high, both for past 12 months and past 30 days. So in the past 30 days, about 9% of young adults were reported smoking cigarettes, 16.1 reported using vaping nicotine, 12.4 vaping cannabis, and then 28.5% using cannabis alone. any cannabis product. And so the arrows indicate an increasing percentage between 2020 and 2021. And the asterisk denotes a historical high since the monitoring the future study has been conducted. So we see that, especially for vaping, nicotine, and cannabis, any cannabis use rates are high and historically high. We also know that nearly half of past 30-day young adult tobacco users report past 30-day marijuana use as well. So co-use between those two products is very high, especially among young adults compared to adult tobacco users, 27.7% of which are co-users. About half of adults who currently use electronic vapor products vaped nicotine only, whereas 7.4% vaped cannabis only, 23.8% vaped nicotine and cannabis, and 14.6% vaped non-nicotine and non-cannabis e-liquid. We also know from previous studies that young adults age 18 to 24 compared to adults 35 and older had at least a 3 times greater odds of vaping cannabis only, nicotine and cannabis, and non-nicotine, non-cannabis e-liquid compared to nicotine only. So the importance of looking at co-use in different products, especially among this age bracket. If we focus on college students as a subset of the young adult population, we continue to see similar patterns, that substance use is among the most critical problems facing college students in the US. Studies finding that between 17.7% to 40% of college students have tried or are currently using e-cigarettes. That in 2021, 40.3% reported any marijuana use, and that 32% reported binge drinking, and 13.1% of college students report high intensity drinking. That is 10 or more drinks in a row in a setting. Not only are college students using many different types of substances, but they are using them together. So we know that polysubstance use is increasing among young adults, and that polysubstance use elevates risk for intoxication, longer duration of physical and cognitive impairment, and adverse mental health outcomes. And as it relates to mental health in 2022, in the Kaiser Family Foundation CNN Mental Health in America poll, found that adults ages 18 to 29 years, 34% rated their mental health as only fair or poor. And this compares to only relatively to only 25% among 30 to 49-year-olds and 18% of 50 to 64-year-olds. We see that the percentage of 18 to 29-year-olds reporting them being anxious was 52%, 33% depressed, and 32% lonely in the figure that we see in the top right. And again, in previous studies, we know that tobacco, nicotine, and cannabis use alone, as well as in various combinations together, are also associated with worse mental health outcomes. So the purpose of our analysis was to look at the association between multiple substance use patterns and mental health outcomes among US college students. So the data set we used were from the Healthy Minds study from 2020 to 21. It is an annual survey of undergraduate and graduate students that was launched in 2007. Colleges self-select to participate in the web-based survey, and then the colleges themselves survey a random sample of their students. We used the data from the 2020-21 survey, and our sample included 83,467 undergraduates across 140 colleges and universities. For our measures or our outcome measures for anxiety, we used the generalized anxiety scale, the GAD, and scores of 10 or higher, they were considered as having anxiety. We used the PHQ-9 scale for depression, and again, scores of 10 or higher. People were categorized as having depression. We then looked at various use patterns of cigarettes, e-cigarettes, cannabis, and heavy alcohol use. We did not include cigarettes as a product because the prevalence of cigarette use was so low. So for electronic cigarettes, we looked at self-reported past month use. Same with cannabis use. We looked at past month self-reported use. For heavy alcohol use, the duration was different, and so it was past 2-week heavy alcohol use. And so for our analysis, we did a sex-stratified logistic regression of single, dual, and polysubstance use on anxiety and depression separately. And our models adjusted for demographic characteristics, various confounders, school clustering, as well as sample weights. And now I'll turn it over to Wura to present the results.
Thank you, Dr. Yang. So next slide. All right, so as Dr. Yang mentioned, the analytic sample comprised slightly more than 83,000 undergraduate students, but the majority being female and white, as you can see in this pie chart here. So to provide some demographic context, participants were mostly evenly distributed across first and second year study, with only a few of them in their fifth year. And participants were also evenly distributed in their living situation. And more females reported experiencing generalized anxiety and depression symptoms compared to their male counterpart. All right, next slide. So as shown in this bar chart, exclusive use of alcohol was the most prevalent substance in this population, which isn't surprising, as we know that many reports have shown alcohol being more ubiquitous among this age group. And we also see exclusive use of marijuana also being more common among the study population. And again, this is also expected given the increasing accessibility and social acceptability of marijuana, like given the new legalization in different states. And dual use of alcohol with vaping and marijuana was also reported similarly among the sexes, and more males reported polysubstance use. That is, they used alcohol, vaping, and marijuana together during that survey period. Next slide. So here we present these stratified regression results where we model the association of different substance use patterns with generalized anxiety and depression. And here we are presenting the results that are just only for the demographics in past financial stress, the parents' education, relationship status, and whether or not they have children, their living situation, and adjusting for lifetime anxiety. So given the proliferation of alcohol use among college students, alcohol use here, we use that as the reference group so that we're able to compare to, we know that alcohol is the most common. So compared to alcohol use, what are the odds of all these other polysubstance use or dual substance use patterns having an effect on anxiety and depression symptoms? And so as shown in this result here, no use was protective. So they had lower odds of depression and anxiety. And all substance use patterns that we looked at in the study elevated the risk for the both mental health symptoms that we looked at. And here we see that females who use marijuana and vape and all three substances also had the most risk for reporting symptoms of generalized anxiety and depression. And I should say that, so this is the stratified results, but we're stratified by sex. So we're looking at the female results first. Next slide. So again, for the females now, in the second model, and okay, maybe I should back up and say that in the first model that we presented, we adjust for demographics. So in the subsequent models, which are labeled models 2 and 3 here, we're accounting for stressors and protective factors. So model 1, which was just presented, right, was the previous slide. And then this slide compares model 1 to model 2 and 3, where we added stressors and social support, just to have a more complete, robust view of what the contexts are surrounding mental health symptoms among college students. So model 1, which is the blue bars, are the models only including demographics. Model 2, the orange bars, include stressors such as financial stress and GPA, like academics. And model 3, the yellow bars, includes all the previous factors in addition to social support factors, which were being part of a community, campus community, and having supportive relationships. And as shown in these bar charts, all substance use patterns increased risk for anxiety and depression. However, when we account for stressors and social support, going across all the models, we can see that all the bars for substance use do go down, showing reductions in risk for anxiety and depression. And only alcohol plus vape product use pattern was no longer significant in model 3, where we fully adjusted for stressors. And of course, we'll offer some thoughts on why the possible reason for this not significant finding in the discussion. Next slide. So now for males, so controlling for demographics, for males, we do observe a pattern similar to females in that no use was protective against generalized anxiety. However, for males, those who used marijuana and also vaped were at higher risk for generalized anxiety and depression. And all substance use patterns did have elevated risk for mental health symptoms, except for alcohol plus vape, which wasn't significant. Next slide. So in these models, accounting for demographics and stressors and protective factor, which is the social support, we found that no use again reduced the risk, and only marijuana plus vape and use of all three substances was associated with increased risk of generalized anxiety and depression among males in the study. And next slide. So overall, poor grades and financial stress increased risk for mental health symptoms, while being part of a community and having supportive relationships, essentially the social support piece, were protective against mental health symptoms. Next slide. So to kind of provide an overarching picture of the results, study findings show that in the context of financial and academic stresses female college students have to face, all forms of exclusive and poly use of alcohol, vaping, and marijuana increased risk of generalized anxiety and depression. With social support, we can see that that risk is reduced, but not absent or eliminated. And for males, in the context of stressors, they're also at increased risk for depression and anxiety, but with the exception of those who only use alcohol plus vape. But when social support was introduced into that model, we did not detect a significant association between exclusive and dual use of vapes and marijuana on generalized anxiety and depression symptoms. So the introduction of social support reduced the magnitude of the mental health risk associated with marijuana plus vape and use of all three substances among males. Next slide. So summarily, all substance use patterns, exclusive or concurrent use, elevated risk for generalized anxiety and depression symptoms among all college students who use them. And given that, college years is one that, is filled with a lot of stressors, such as the academic stresses and financial stressors, we see that this is a significant contributor to the risk for generalized anxiety and depression symptoms, especially with these students who are using alcohol, nicotine, and cannabis, albeit maladaptive coping mechanisms. And social support, which we defined as in the study as being part of a community and having supportive relationships, is protective, but alone, it does not eliminate the risk of generalized anxiety and depression symptoms among users. Next slide. And so when we stratified by sex, all patterns of substance use after adjusting for presence of stressors or protective factors increase the risk for generalized anxiety and depression among both sexes. And cannabis plus vape users among both sexes were the ones with the highest risk of reporting generalized anxiety and depression symptoms, which could be a function of college students using this product for negative reinforcement. So for example, they could be using substances to alleviate the negative affect for mental health symptoms. And of course, the problem also of the marketing of and promotion of recreational cannabis for medicinal purposes is also not helping them and aggravating this problem. So our findings do highlight the unique but complex impact of simultaneous use of alcohol with other substances on mental health of college students. Next slide.
So in terms of thinking about next steps and how to move forward with some of these data, I think it's important to remember that we live in a very different policy and product landscape, and it's constantly evolving. In California, certainly we had Prop 64 in 2016 which legalized recreational marijuana use, and we see that throughout the United States, more and more states are legalizing recreational marijuana in California, but also in other states and localities as well. You have efforts to prohibit flavored tobacco products. And so what we see is that interestingly is that in many ways, marijuana is becoming more available while tobacco control policies are putting greater restrictions and limitations on tobacco products. And what the implication that is for what products are available to be used and changes in use patterns, I think is something to consider as we move forward. And then, of course, thinking about the social context within which college students live in, right? We certainly saw a lot of experience COVID-19, even though our current situation is better. I think the after effects of going through that experience and sort of, whether we go back to life before as it was before COVID-19 or whether or not there's sort of a new normal, I think these are things that we're still trying to figure out within the university and college context. Certainly, we live in a period of heightened social and economic instability, whether that's looking at sort of the economic landscape or sort of the political climate that we live in. It's just a very different environment and very unstable. And certainly increased cost of living and the increased cost of higher education in general, right? These continue to be stresses or sources of stress that are oftentimes outside of the control of students. And so it's important then to continue to look at and to continue to monitor the relationship between substance use and mental health, but to also look at the changing landscape of product use and product availability and the sources of stress and mental health among college students. What can we do sort of at the university or college level? I think certainly preserving student health and wellness needs to be seen as an essential element of success. Unfortunately, I think in many cases, you have colleges and universities that focus on crisis intervention. And certainly that is incredibly important, especially around high stress periods like midterms and finals. However, for universities and colleges to only focus or to put most of their attention on crisis intervention is not really enhancing mental health or preserving mental health. And so how do we incorporate a ethic and an ethos of student health and wellness as part of overall campaigns to improve student success and to enhance student success, I think is a critical conversation to have within the university setting. Certainly, and as I think we'll probably talk about the importance of addressing mental health within substance use interventions and to also address substance use within mental health services because these two seem to be very closely associated. We don't want to address various conditions or health outcomes in isolation, but to look at them together. And certainly, moving forward, thinking about university smoke and tobacco-free policies, at least in California, we sort of had a high activity period, sort of in the mid-2010s around the UC system and the Cal State system passing smoke and tobacco-free campus policies. But as we know, as experience has taught us, that policy passage does not necessarily mean successful or committed implementation on the part of universities and colleges. And certainly any implementation efforts is only one part of reducing overall use. It's an important part, but not the only part. And so as we consider more complete and robust efforts to look at tobacco and other product use and their relationship with mental health, we need to, I think, reconsider where the leadership in this area is going and how we can get universities and colleges to commit to putting more and more resources to ensuring student health and wellness. We are happy to take questions, both Wura and I, on any of our parts of our presentation. If you'd like to contact us for any additional clarification or data, we'd be happy to do so. Our contact information is here. We want to acknowledge the California Tobacco-Related Disease Research Program, which provided support for this work. Thank you very much.
Thank you both so much. And we do still have some time for any questions that anyone may have. Again, you can put it in the chat box or go ahead and unmute yourselves. Okay, we do have a question in the chat box. Were the participants all cisgender?
That is a good question. Wura, I'm not sure if you recall the data on gender and
Yeah, so we used biological sex act in that. We did not ask about gender or gender identity. I'm not sure the data has, perhaps it does. Maybe that's a chameleon questions, but the analysis was looking at sex differences, not gender identity.
There's
Well,
another question in the chat.
Sure.
Yes.
Were the participants asked if they use substances in isolation? We did not ask, we did not look at setting within which the product was used. We only looked at self-reported use within the specific time period. That is 30 days for vape and for marijuana, and 2 weeks for alcohol use measure that we used. So we didn't get a chance to look at setting.
Are there any additional questions? Okay, yes, I just following up with what Ang said in the chat. Thank you. You both did great work. Thank you for the data and the research. I agree, that was fantastic. I really also appreciated your insight on the discussion points. I think those are all really critical conversations that we need to be having, moving beyond just looking at policy adoption, but what does that mean after the fact, and how do we just support overall student wellness? So thank you both so much. I'm going to now take over the conversation and really talk about what are some factors that impact use. But before that, I hope you all will offer me the ability to transition just a little bit, because I want to think back to Ethan's question about were all the participants cisgender. So want to note that this is not my research, that I just pulled this from the most recent ACHA-NACHA, which is the American College Health Association National College Health Assessment Survey, which they administer every year. And they recently released their summary report for fall of 2022. And within their recent data, they do have large enough sample sizes of trans and gender non-conforming students. And they were able to pull out some data looking specifically at substance use by gender. So I did a talk on this last week, and I'll just share with you this one slide of this presentation so you can kind of see what it looks like. I want to note also that the trans and gender non-conforming data are not disaggregated, so we don't know if trans male, trans female, or non-binary students, but you can see some of the differences, looking specifically that there's not a significant difference with use among gender identity within tobacco or alcohol use, but there is a pretty significant difference among marijuana use. So I found this really fascinating when I was reading the report, and I'm also happy to share this slide set or share the report from the American College Health Association after this call, but they did look specifically at trans and gender non-conforming students in their most recent data set. So it's a really great report to look at. So I am now going to share my actual slide set with you all. And what we're going to be talking about, just touching a little bit on some data, but more so talking about the realities of what we're dealing with from the landscape of student tobacco and marijuana use here in California. And I just want to specify that it is specific to California simply because we are a state with legalized marijuana, and that definitely has an impact of what's happening. And because we have some other factors that are impacting student use. So just jumping in, I want to start off by noting, for those of you who have been around for a while, you have also probably observed that we have seen a pretty significant change in college student behavior. So I started in this field shortly after I graduated from college. And when I started, it was right after the Master Settlement Agreement was signed. That was a large agreement that was signed between 46 states, California being one of those states, and several cigarette companies. There was later a smokeless tobacco master settlement agreement as well. But one of the really signifying aspects of the master settlement agreement, or the MSA, was that the companies agreed to stop legally targeting youth. And I say legally targeting young people because we know that that behavior continues today, but it's done very differently in the sense that we no longer have cartoon characters that the tobacco companies use to sell their products. But what we saw was a pretty dramatic shift on how the tobacco industry shifted their marketing strategies to try to reach the young adult community. And as a result, we saw an increase in smoking specifically among young adults. And that's really when we started to do work with colleges and universities. And there was actually a time when we didn't do a lot of work around tobacco use on campus, but instead addressed all of these other things that the industry was doing. They were sponsoring bar nights near college campuses. They were sponsoring Greek events. I recall I did my undergraduate at UC Davis, and I had a friend whose husband was in one of the fraternities there, and he was an employee of US Smokeless Tobacco Company. It was his job to go to the bar events, which were the bar they went to was catty corner from where freshman housing was, walking distance to many students that were living there, as well as transfer student housing. They also hosted US Smokeless Tobacco events at their property, and at all of those sites, they would distribute free products. I recall California used to monitor the bar nights, and I would go to these events and they would just allow you to stick your hands in these large duffel bags filled with cans of dip and take as much product as you want to. So obviously that's changed, that's not happening anymore, but these were the realities of what was happening in the early 2000s to try to promote and attract young adult students into substance use, or specifically tobacco use. The industry used to also provide scholarships and sponsor collegiate rodeo. Our college rodeos, which I believe we have 7 still here in California, those are club events. They're not NCAA events. Therefore, the tobacco industry can sponsor those events and those athletes. They also do couponing, which is a significant problem that continues today. The industry, what they do is they get your information at bar events. They used to swipe your ID to get your information. Now they just get it through, you can sign up for different things, or if you're out at a community event, if they happen to be there, they collect that. And the intention of that is to make sure that they can send you coupons to make it cheaper for you to purchase that product. And so again, this was a huge tactic of the industry way back when. It continues to be a really important tactic of the companies. But they also used to do things like distribution of vending machines to campuses, specifically to fraternity houses. This seems like it's archaic, but we dealt with this issue in Los Angeles County just a few years ago with Juul and them trying to put vending machines into Greek housing. And then, of course, another issue was that they would go to colleges and universities and do job recruitment. And obviously, that's not a way that they're promoting their product, but what they are doing is they're promoting corporate responsibility. It is the job of the tobacco industry to make all of us think that they're okay, that they're part of our community, that they're not bad, that really they're our friends. And this has been a challenge with a lot of the work that we're doing, not just with tobacco, but we're also now seeing it with the marijuana industry. But after the Master Settlement Agreement, what we really started to document was that the industry created a culture of social use. This was very difficult because individuals were changing from being a daily tobacco user or somebody who smoked every single day to non-daily or social tobacco use. This was definitely a struggle when trying to have conversations with students, because you would talk to them and say, oh, you smoke, and they'll go, oh no, I only smoke if, or I only use tobacco when I'm out partying, when I'm at a school event, when I'm drinking. And so because of these parameters, because I only smoke when, there wasn't that connection that, oh, I'm a tobacco user. And if you're not in your mind a tobacco user, then you're not somebody who should consider quitting or somebody who wants support in quitting. And so because of that culture shift, we also really had to change how we did our outreach and our prevention. We really needed to reframe the message so that we were denormalizing tobacco use and not recognizing that it was a social norm for everybody to be using these products. We also really had to figure out, how do we motivate quitting? When was the best time to support young people in changing their behavior and trying to quit using these substances? And in college spaces, that's always tricky because you're dealing with academic years. You're dealing with different stressors that exist with the time of the year, with midterms, with finals, with holidays, with graduation parties, with all of these different things. So really having to look at this and figure out, when do we connect in these messages and offer these services? And a lot of the work that we were doing from the prevention side, from the education side, from the treatment side, and from the policy side was really showing an impact. And we saw a pretty significant decline in young adult smoking over the years. And in 2017, it looked like things were going really, really well. And then we hit the youth vaping epidemic. And this is something, obviously, it started before 2018, but 2018 is when the Surgeon General released an advisory statement recognizing that vaping was an epidemic among young people. And this was directly associated with new products that were discreet, they were flavored, they were highly addictive. And for that, we can thank Juul. I think it's safe to say that Juul really could accept the blame, and they did recently accept the blame with California. And there's a massive settlement that our state just entered into with Juul for leading to the vaping epidemic here in California. But what Juul also did, which is really critical to note, is that they changed the formula with the nicotine. And so prior to the pod-based products that we have now, or the single-use, young people like to call them disposable, we always try to change the language a bit when we can, because these products are not at all disposable. But what Juul did was they introduced a nicotine salt solution instead of the free-base nicotine solutions that were being used. The issue with the free-base nicotine, and free-base nicotine is all in other tobacco products like cigarettes and the old school smokeless products. But the free-base nicotine has the acids removed. Nicotine in its natural state is actually a nicotine salt if it's found in a tobacco plant. And the free-base nicotine had a higher potency, so they could keep the dosage down. But coming from a vaping device, it was a pretty harsh throat hit. It was hard for people to consume in large quantities. And so what we found is, with the first 3 generations of different vaping devices, the first generation being cig-alikes, the second being pens, and the third being the mods and the tanks, they kept getting bigger and bigger and bigger, so that individuals could get more aerosol and get more of that nicotine, so that they could be satiated and they wouldn't have to do dual use or use of a cigarette and a vaping device. But no one was really able to capture that until Juul. And so in comes Juul, they switch it to a nicotine salt solution. It's a much smoother throat hit. They can put this solution with high concentrations of nicotine, but in smaller devices. So individuals are getting less aerosol, but they're getting more nicotine, and it's easier for them to take in and easier for them to absorb. And as a result, with these changing products, we saw a couple of things. One, we saw increased use. We also saw increased use in smoke and tobacco-free spaces. This is a huge issue that we deal with today with K-12 schools, and also with colleges and universities, all these spaces that are smoke and tobacco-free, but the products are really easy to hide. And so we saw that jump in 2018, and then we saw it peak. Almost 28% of high school aged teens reported current e-cigarette use in 2019. That is very problematic. This is national data. This is not California data. California data was significantly lower than what it looks like nationally. But I'm sharing this because it's important to note that the youth vaping epidemic are today's young adults. And this is something that we can't ignore, that we talk a lot about what can we do to prevent youth from using these products? How can we support youth? So I'm really grateful to be here today to be having this conversation around young adults, because this is not a youth-centric issue. This is an issue that's impacting young adults as well. These young people who were part of the vaping epidemic of 2018 are today's college students, today's young adults who may not be in college, and they're the young people that you all who are working with colleges and universities are now supporting and quitting. So as Nan had shared, we saw a pretty significant increase in vaping nicotine among young adults, specifically in college. In 2019, there was a peak. This is from the Monitoring the Future study. We saw a greater increase in college student vaping than we did young adults not in college. So what's so significant about that is that we know that in the past that college attendance could potentially be a protective factor for young adults in reducing the risk of cigarette smoking, but that is no longer the case with these other products. And so I just want to share a little bit more data from the Monitoring the Future study. This is looking at non-college young adults and then college young adults. I like this data set also because it's 18 to 22-year-olds. And the part to look at that is troubling from our perspective is that uptick in cigarette smoking among college students. So again, I just talked about how college attendance is a protective factor with cigarette smoking. This is a trend that we will be keeping a close eye on to see, will this change? Is this just kind of unique because of the pandemic and some changes there, or is this something that we should be paying closer attention to? So now we're not dealing with just a social behavior anymore. Vaping, smoking, tobacco use. And when I say smoking, I'm not just talking about cigarette smoking, but we now know that more young people are using these products on a daily basis and not just non-daily. Recent data from the National Youth Tobacco Survey also found that about a quarter of young people who report current vaping are using products daily. So that shows the addiction. And what we know is that both the age of initiation has increased or decreased, so people are starting younger, and addiction is setting in earlier. So what that means is by the time a young person gets to a college campus, that addiction has already set in. We used to look at the behavior and say that young people might experiment with tobacco before the age of 18, and then they would become addicted during their young adult years or college years. And so we could really focus that messaging in a college setting on like, hey, how do we prevent somebody from transitioning from experimentation into addiction? But that has all changed because as students are now leaving high school and coming into college space, that addiction has already set in. And why is this? Part of this is the products have dramatically changed. So in 2017, 2018, we were dealing with Juul. What Juul did was they tried to replicate the experience of smoking a cigarette. One pack of cigarette has 20 cigarettes, and each cigarette has about 1 milligram of bioabsorbed nicotine. So Juul said, okay, great, there's 200 puffs in a pack of cigarettes. Let's replicate that with 1 Juul pod being 200 puffs, but we're going to double the amount of nicotine in there, and they have 40 milligrams. Today's version of the Puff Plus or the Puff Bar has 5,000 puffs in it and 550 milligrams of nicotine. That's almost 14 times the amount of nicotine in a Juul pod. And not only is it higher in nicotine, but I also want to note that the puff volume is very, very important because a lot of young people will share devices, meaning it's easier to get the products, it's easier to get access to nicotine than it was if you're sharing cigarettes. And not only have we seen a change in nicotine products, but we are also seeing a significant change in THC levels within different marijuana products and devices. Potency has increased from about 4% in the 1980s to an average of 15% today. With some products and extracts such as dabbing and some of the edibles, they could have up to 90% THC. This is a massive struggle that we're having, especially with youth and with young adults, because a lot of young people will say, well, I get my products from my parents and they used to smoke weed when they were younger and they were totally fine. But I can tell you the weed that people smoked when I was in high school and in college is not the same thing that young people are smoking, vaping, and eating today. These products are evolving. They are constantly changing, not only the design, the delivery, but also the substances that are in there. We have transitioned from the free-base nicotine solutions to now nicotine salts. We have new smokeless products that are not just a nicotine salt, but it's a nicotine salt powder that is synthetically made. They're higher concentration of nicotine, higher concentration of THC, higher puff counts and volume of all of these devices. And unfortunately, all of these things appear to be safer or less risk for young people, which means they're more likely to experiment with them than they ever would have considered for a cigarette or other combustible products. And as a result, we unfortunately have renormalized smoking and vaping and the use of tobacco and marijuana in California. So not only now are we looking at the smoking of tobacco and we're trying to kind of remove that from our space, because if we don't see people smoking or vaping, it denormalizes the behavior. If we can remove the advertising and marketing, it denormalizes the products in our community. But the marijuana lobby is completely reversing that. We have different regulation over marijuana products than we do with tobacco. And Dr. Yang mentioned that, we have legalized marijuana, but we have banned the sale of flavored tobacco products. I was in a presentation with parents a while back and they're like, oh, so my kid can't get a flavored nicotine vape, but they can get a flavored THC vape. Correct. So we have a lot of struggles here that we have to kind of work through, and the realities of the marketing that we're seeing from the marijuana lobby, but all of this just is renormalizing use, renormalizing the behavior. And access is an issue. So there is data from the California Department of Public Health that shows that young people, remember we have a T21 law here in California, it's the same with marijuana. You should not legally be able to purchase under the age of 18. But most young people who are getting their products are still purchasing them locally. We also know that a lot of young people are sharing products. And we know that after our T21 law passed, that we actually saw a very significant increase in sales because we changed that age, and a lot of the decoys who are purchasing are now older. They're young adults. They're not those 15, 16-year-olds. I also want to note that our colleges and universities are not protected by the same laws that our K-12s are. So oftentimes we work on local licensing laws and we try to prohibit the number of retailers that are near a K-12 school or near a park or somewhere where youth are. But rarely do these policies include colleges and universities. And what research has shown us is that specifically with shops that are young adult friendly, for example, hookah shops, that they're more likely to be placed near a college or university than any other location in the community. So it's really important from a public health lens that our retail policies include colleges and universities as well. But we also know that we're struggling with these issues of access. And so now in California, we can get delivery. We can get delivery of marijuana products. And for some campuses, we can get delivery of nicotine products. This is an issue that we're dealing with some of our UC campuses in Southern California and the Bay Area. There's a company called Duffel, and students can order nicotine and tobacco products to be delivered to them right on campus, even though under campus policy, they can't use the product and they can't purchase it on campus, but they're technically not purchasing it on campus because it's coming from an app from a local retail. The other challenge is we have a lot of mixed message. So when we talk about tobacco use, if somebody reports tobacco use, we advise them to quit. When we talk to youth about marijuana, we talk about not using marijuana, it's not safe for them. Brain development is an issue. But then oftentimes when we talk about 21 and over use, we switch the marijuana conversation to responsible use, even though brain development doesn't stop until the age of 25. And so there's a mixed message of, okay, it's safe until I'm 21 because that's the legal purchase age. So now I can continue to use it, but I just need to be using it safely. So it causes some sense of confusion there. And then even more confusing is the sense that marijuana lobby and a growing industry and these companies are really controlling the conversation around the products, because again, there's no regulation over what they say and how it's said. And so when we talk to a lot of young people, it's believed that marijuana can be a medicine, that it's safe, that it's not addictive, that it's really okay for use. What we know is that students may be using tobacco and marijuana, and we heard a lot of this morning, to cope with stress, anxiety, depression, to escape from reality. Unfortunately, we do know that young people are reporting use of the substances for self-harm. But there's also the piece of connecting and fitting in with peers. And then a lot of the co-use, so for example, smoking a blunt, which is a tobacco leaf with marijuana, it's a combination of getting the highs and the lows from mixing the two substances. I want to note, and just following up for some of the things we heard today, some of the unique factors associated with college students and mental health and stressors is that these are young people who have extreme academic stress, not just at college, but coming out of college. Getting into a college is very high stress now. And so they are coming in and then they're in this space. There's stress caused from exams, there's stress caused from coursework. And then the reality for many young people is that they're also working and going to college. We have increasing tuition. The cost of living in many college communities is out of control. And young people need to work 1 or 2 jobs to be able to just pay for college or for living expenses, plus they're going to school. If they're working and they're going to school, they have less time for social interaction. They're less connected. And then this was all worsened by the pandemic. And as a result, 3 days ago, our Surgeon General released a new report saying that we have become a lonely nation, and that loneliness is directly associated with worsening health outcomes. And we know it's also associated with increased substance use. And there's a particular focus on youth and young adults, recognizing that young people today are lonelier than they ever have been before. So with that, I'm going to end my talk, and I do want to just note that it is time for a break, but we can stick around for any questions that anybody has. And then also want to note that going in from this conversation, we'll be diving much more into the conversation on substance use and much more into looking at substance use and mental health. So thank you so much for your time and for listening to this panel today. And now just want to open it up before we jump into break to see if there are any final questions, either for myself or for any of our other speakers. Okay, I am seeing none. And so what I'm going to do is encourage you all to go take a break, grab some more coffee or something to eat, and we will be back at 10:30 to hear from our next presentation. And I'm really excited about what's to come. It's a lot of learning, a lot of discussion, and great engagement. So take a break and we'll see you back at 10:30. Welcome back, everybody. We're going to come back from break and move into our next session. I am very, very excited to introduce you all to Wang Ta. Wang is a licensed MFT clinician with experience in healthcare, college and high school campus care, and community treatment. Wang has a long history of understanding and treating substance use in youth and young adults in various settings, and has worked with systems to integrate mental health and health service screening and treatment. Wang is a consumer provider that specializes in substance use, addictions and recovery, trauma, and systems transformation. With a radical approach to healing, therapy, and design, Wang does not think outside the box, but instead has a think as if there is no box exists approach, which I might steal that. I love that. That's awesome. So if you could just join me in welcoming Wang to discuss and explore how we can collectively and holistically approach tobacco, vaping, and marijuana cessation as we continue to support colleges and college campuses through their struggles. So thank you so much for being here today, Wang, and the floor is now yours.
Thank you, Kim. Can you all hear me well? All right. I also want to thank Nan, Dr. Jacobs, and Dr. Yang. Like the information you put forward, it actually covered a lot of my talking points. So I was revising as I was going. It's like, oh, this is perfect. And you all set the pace and the landscape of what we're working with through the data. And so I just want to make expectations very clear that this is going to be discussion. I don't use PowerPoints. I don't use a lot of presentation. It's more facilitation and more exploration discussion about trying to figure out what the smoke is and what the fire is, right? Because oftentimes the data will show the smoke. It will show the results of questions asked, and then the fire is, what are we really getting at? And it's something that Dr. Yang brought up was, what is this holistic approach, this work around wellness and health beyond the policies? How do policies transition to practice? In order to do that, we have to actually step back and look at some of the data that even Nan talked about, with the mental health relationship with substance use. And primarily in this situation, in our environment, is cigarette use, e-cigarettes, vaping, and cannabis. But it also, when we look at polysubstance use, it extends beyond that. Because most oftentimes when someone engages in substance, no one wakes up and says, I want to be addicted to a substance, right? If you start using something, there's several reasons why, and we want to explore why. And what's the mental health impact? How does it impact mental health? And how does mental health impact that? And how does it cycle? All right. So feel free to ask questions as we go along, because I know questions will pop up, and I will be asking you all some questions. So it's not sit back and listen. It's a little more dynamic and a dialogue. All right. So I want to touch upon some points that also Kim brought up. Right. That quote, "I only use this when," which creates this situational narrative. Right. I only use this when I'm anxious. I only use this when I'm with people or at parties. The question we never ask is why? Why at parties? Right? And oftentimes it'll be, oh, because everyone else is doing it, which indicates to me some form of self-regard and self-esteem. If everyone does it and you have to fit in because we all want significance and belonging, all right? The basis of our mental health issues is significance, to matter and belong. If you want to fit in, then it's a depression issue. Or if you get anxious around people, that's an anxiety issue. And we often know that as a clinician, I work for Kaiser. I do the crisis line and I do the triage line. I also provide groups, and I'm duly licensed in substance use and therapy. I know, and I can tell you, I see this time and time again, depression and anxiety go hand in hand. It's not one or the other. And the questions we ask usually drive us to think it's one or the other, right? Sometimes when someone's depressed, their thoughts about not being good enough, failing, not having energy, lead them to be anxious. Or when someone's anxious about failure, they become incapacitated and unable to do anything. They have analysis paralysis, and then they get depressed about not doing what they intended to do. They go hand in hand. And sometimes there's a third thing that causes both. And in most cases, when I do assessment and I ask if people use substances, the substances usually aren't the problem. They are the medication and solution. Right? And so in this conversation, in this dialogue, and as I bring information, I invite you all again to ask questions. We're going to explore the three realms of what we're aware of. Right? How we construct mental health and substance use. The first realm is everything that we are aware of, we know about, right? You're aware about it, you know about it, you understand. Then the things that you're aware about that you know nothing about. Like me, I know physics is there. I know quantum physics is a thing. I know nothing about it. The last realm is everything that we're unaware of, because we haven't asked those questions, right? And that's where we want to tap into today. That's the dialogue we want to have, is asking those questions that haven't been asked, thinking about the things that are not being caught in data. So then we can ask those questions and ask that data. Like the question asked earlier, did we ask questions about, are they using substances or smoking in isolation or with people? Because for me, whenever someone does something alone, it is a red flag for mental illness or a wellness challenge. Right? Yeah, you smoke, you drink with people. That's something you do socially, right? It's a social norm. We said it. We heard it in multiple narratives. Jewel did a wonderful job at making sure this has become a social norm. You only do it with people. Now, when you start doing it alone to get the same effect, you got to ask yourself, why? It's no longer social. Right? And to your point earlier, when you made the, Kim, when you made the differentiation between the free-based data and the salt data, there is a good reason for why people are increasing their usage of Juul with salts. The acid, for those who don't know, a lot of this session also is going to be level setting, getting us on the same page so we have the same understanding of what's going on biologically. Anytime the acid is introduced, it's not absorbed easily into the blood-brain barrier, right? So you add a base to it, cleave off the acid, and it gets absorbed faster. Well, the acid makes it faster, right? And so you see this with cocaine, except cocaine and crack was different. Crack, you smoked, it came in faster, the hit dropped faster. But when you snorted it, it entered much slower because it was a snort, right? You took it, inhaling it, and it entered the blood-brain barrier slower, but the effects lasted longer. So when you see this with Juul and they switched it to a salt, they made it so that it was smoother. It also didn't absorb as quickly. So you end up taking more in over time. And you'll see this. Some people will take one hit of a free base versus they'll do one or two, and then a couple minutes there, do it again because they're not feeling the physiological impacts. And how does this impact the body? How does that show up in mental health? Well, our bodies will tell us if we're feeling some form of a wellness challenge. Our bodies will feel it first. Right? People who have depression will often feel tired, fatigue first before the confusion or the lack of motivation kicks in, right? The lack of motivation is really low energy, no direction, or having something else take precedence in the priority. So let's step back again and see how these tools that people use to treat their own challenges, their anxiety, their depression, or their stress, right? The cigarettes, the vaping, and the cannabis, how that impacts the body. All right. Anyone here, just you could use your hands, use their emotes, aware of the vagus nerve. Anyone know about the vagus nerve? Yes. Okay. We have at least one person. Great. And for those who don't, the vagus nerve is a nerve in our brains and our body that connects with our midbrain, where memories and emotions are processed. All right. And so this is responsible for that feeling you get when you hear a certain song and these feelings come back. Oh, when you smell something, you're like, it smells like this holiday or this event. And you can't even picture the specific thing, but you know what the feeling is like because you smell it. That's the nerve responsible for that. And that nerve is actually connected to most of the vital organs in our body. This is the same nerve that when you go through a severe breakup, you experience a loss or you enter grief or severe depression, your chest hurts. Because the nerve sends signals to the muscles around your heart, which weaken the muscles around the left ventricle. And so the left ventricle pops out of place, formerly called Takotsubo cardiomyopathy, squid trap heart attack, because a Japanese squid trap was a vase that was flat on one side and enlarged in another. Or apical ballooning syndrome in the medical field. To us, we know as broken heart syndrome. Your heart literally broke from a memory or a feeling or experience. And our bodies are trained to feel these things physiologically. The issue with some of the questions we asked, like the GAD-7, the GAD-7, asked 7 questions. And the only one around physiological responses is feeling restless, which can also be attributed to your mind being restless. It doesn't ask about having acid reflux, muscle tension from acid reflux, burping or farting, which is a symptom of increased acid production, muscle tension, sweaty palms, which are all signs and symptoms of anxiety. So when you see the discrepancy in some of the data, sometimes people may not be reporting anxiety because we're not asking those questions. Especially when we look at race and gender, right? For some folks, you kind of raise in a way where the issue comes up, you just got to get it done. You got no time to be anxious, get it done. And so you don't think anxious, you think problem solving. You don't feel anxious because you think I got to get it done. Otherwise, that's my survival. But physiologically, you get knots, you get constipation, diarrhea, your stomach churns. When you sit down and relax, your stomach hurts because now it's hungry. And these are symptoms of anxiety that you don't think or feel. And what does these products do? These products alleviate some of those symptoms immediately, yet they also contribute to the symptoms. Remember how I said the vagus nerve is connected to your feelings and your memories? It connects also with your body. So there's some things where if you hear something or you feel something, your body will trigger it. I see this panic disorder and generalized anxiety that when their hands start getting sweaty or their heart starts to palpitate, if you ever had a panic attack before, everything that feels like a panic attack will cause you to have a panic attack, right? Anxiety is on that spectrum. Stress at some point is no longer part of your flow. It's not optimal anymore. Then it becomes anxious, then it becomes toxic, then it becomes traumatic, and there's panic. So when your heart starts to beat fast, you're like, oh, am I having a panic attack? And then thinking about having a panic attack, you end up having a panic attack about panicking. It's the same way when you lay down to sleep and you ever ask yourself, anyone here ever ask themselves, am I awake still or am I asleep? Which causes you to wake up? Yeah, that's what happens, right? You say, oh, am I having a panic attack? I think I'm having a panic attack. And then your heart starts beating faster. So the thing that happens when you smoke or you vape, nicotine, one, increases your systolic blood pressure, right? So when there's an increase in systolic blood pressure, about 5 points of mercury, which is enough to give you high blood pressure, it doesn't increase the diastolic. So when it increases systolic, you're actually feeling your heartbeat faster and you're feeling the tension, right? At stage 1 of high blood pressure, your body physically feels it. And so now it automatically thinks I'm anxious, even though the drug is tricking you. Same thing with cannabis. Cannabis is anticoagulant features. Also, anytime you smoke something, if you smoke marijuana, it thins your blood. So your heart beats faster and harder to get the blood flowing. It also constricts, right, your blood vessels, increasing your blood pressure. But because cannabis effects in low doses of THC causes memory loss. So you don't remember that you're actually anxious. And unfortunately now, cannabis has higher THC concentrations, right? Back in the 60s, it was around 6% to maybe 11. Now we're starting at 12 to 24. And depending on the ratio you have, so the higher THC content, the actual more symptoms you're going to experience that look like psychosis. You get paranoid. That's the first symptom most people get. They get paranoid. Did you touch my food? And then you can't remember anything. So now you're actually confabulating because you can't remember things. You start filling in those blanks. Then you get anxious. Go ahead. I see. Oh, usually if someone comes off mute, I assume you have a question you want to talk. So I'm going to call on you, right? Because I want to make sure you're heard. So this is what happens with cannabis. And then your body remembers that. You may not, because cannabis will get rid of your short-term memory, but you won't remember what it's like. And all of a sudden you're sitting down, you have a heart palpitation, and then you go into panic and you don't know where it comes from. It's because you had a panic attack when you smoke cannabis. See, cannabis is also a setting drug. It's a hallucinogen, meaning whatever you feel, it's going to amplify, right? So people use it to sleep. Sadly, most of the time people can't sleep because they're anxious. So if you're going to sleep anxious, you're going to dream anxious. You're going to wake up tired because you're anxious. At night, your body doesn't know the difference between sleeping and awake. If you're dreaming from running from clowns all night, you're going to wake up tired because you ran from clowns all night. Does that make sense? And this is what cannabis does. Setting. Alcohol is also setting. Even though it depresses your central nervous system, it actually increases your blood pressure because it's depressing your central nervous system. And your blood pressure will jump and it will also drop. And depending on how you're feeling, it can either cause anxiety or act as an anxiolytic, which it is. Alcohol is pill form benzodiazepine. I mean, it's liquid benzodiazepine. They work on the same part, and they get rid of anxiety. They get rid of the emotional anxiety. The physiological symptoms are the same. You ever have a panic attack on alcohol? Your brain and your body will remember that, whether or not you feel it. So what happens with mental health is people will use substances to alleviate mental health symptoms, the feeling of it, not realizing they're triggering their physiological symptoms, which contributes to it. Right? There's a cycle that happens. And then people start using it alone. How many people know somebody that when they lay down at night alone, those negative thoughts and those questions come in? That self-doubt, did I do this? Did I finish this? Am I doing enough? That comes in. Right? Many of us can identify someone in our lives that have those thoughts. College students, especially college students who are already starving to begin with, can't afford the classes or the books, right? They're photocopying their books, especially now when no one can get a job. And they have stress around school. They're laying down thinking about the things they have to do, that they did not do, that they need to do on top of the things that they have to do tomorrow. Then they decide, I'm going to smoke, whether it's a cigarette, an e-cig, or cannabis to try to go to sleep. And you're going to bed with your body already elevated. Right? It is a lot of information. But we have to ask these questions. Why are they using this substance? And if we decide to create policies to end this substance, what are we using to replace those strategies, right? Nonviolent communication is one of the modalities that we utilize when we're exploring behaviors, right? And there's multiple assumptions, but two of the most main important assumptions are every choice, behavior, and action you do, every decision you make is to fulfill some universal need you have, right? If you eat a sandwich, it's because you need food. You get in an argument, it's because you need to be heard. The other assumption that's important is we actually don't have problems with each other's needs. We have problems with each other's strategies. I got no problem with you being hungry. I have a problem with you eating my sandwich. In this scenario, we have no issue with people meeting their needs for mental health and wellness. We have a problem with them smoking, especially on campus. But if we take away someone's strategy, what are we doing to replace that strategy? Because if I took away someone's food, what are they doing to get nourishment? Right? And we've seen this. There are policies that have been enacted, across the state. Hayward, for example. Hayward is a city in the Bay Area. And, several years, almost a decade ago, actually, or more than a decade, they enacted a law where you can't smoke publicly in Hayward. You can get fined, right? So great law. Only problem was now people were just stepping on people's private property and smoking as long as the smoke didn't hit the sidewalk. If the smoke doesn't touch a sidewalk, you can't get fined. Are people smoking in their cars? Did it stop smoking? No. It stopped it in public places. So what are the policies that we are doing to enact? What are they doing, and what are we intending them for to really do? What do we want to happen? We want people to have a healthier lifestyle. So we got to ask ourselves questions. How does it move them towards a healthier lifestyle? How does it address the mental health need? Because most of the things that we see are to address some health need. And let's also take a step back and let's redefine mental health. Mental health is health. We keep talking about separately. It is health. And there was a time when we treated mental health as separate, as not a thing. The brain wasn't part of the body. And before that, that's also a time when we prohibited substance use like alcohol. And then we criminalized the doctors that were treating cocaine addiction and opioid addiction and alcohol addiction. Yes, in the early 1900s, we started criminalizing doctors. Doctors stopped treating patients, and then people started going to prison for it because doctors were no longer treating people who were addicted to substances. Are the policies recreating, replicating history? Because when doctors stop treating it, well, we can no longer control it. It's criminal. And when people are punished for it, it adds stress. Stress diathesis. The more stress in someone's life, the more symptoms, right? If you're depressed, more stress, more depression. If you're stressed, more anxiety. If you're stressed, more smoking, more edibles, more use to get rid of that stress, to forget. So what are the policies we're creating that actually work on multiple levels? That yes, we can create a tobacco-free policy for campus. And what else are we doing that takes care of those needs with different strategies? So that youth, young adults have ways in which they can address social anxiety, that can address memory issues or address issues with usually undiagnosed learning disorders, self-medication, identity, right? Remember, the two foundations of people's mental health is feeling like they matter, like there's supports for them, and feeling like they belong. So I was excited to see the information you presented, Kim, about the trans and queer identity, right? And non-cis, non-binary. And I'd love to see what it looks like disaggregated, because also in the social context, different people experience different things. And we also know there's a disproportionate amount of suffering and suicidality amongst Black trans youth and young adults, which makes sense why smoking is elevated, because that's something you usually can do alone. Right? Cannabis use was elevated. It was higher. It was like 37%. Because a lot of people will smoke cannabis alone, usually to go to bed, when they're fighting their own thoughts alone, being reminded by the world they don't belong, being reminded on campus they don't belong. So I'm excited also to be in this space, because I know some of the colleges are doing great work. And unfortunately, most campuses don't have a separate substance use program because it's criminalized. I mean, to say, hey, I'm using opioids goes in your record if you start using campus services. Do I want the campus to know that I have an opioid addiction? Especially when there's a zero tolerance policy. If there's a zero tolerance policy on anything, do I want the campus to know that? And so I love how a lot of the health clinics are integrating into their care. And health clinics are integrating the care in the way where mental health and health are basically the same, right? And we got to treat it that way. We got to de-silo. We got to get rid of these silos. We got to look at what's going on and look at what we need to do. Ask these questions. How is it helping youth right now, right? How are we giving people strategies to meet their needs other than using the substance? How do we develop a culture and a social context in this school, in this campus, in which they can receive those things? And it's not separate. It's not a separate service. It's integrated so much at the campus that it's talked about everywhere you go. When I worked at a high school campus, it was alternative education. So I had 17-year-olds to 21-year-olds entering into college, and there was alternative education. It was credit recovery. We built a system that was, and it took 2 years. It's not going to be quick fix, y'all. A single policy is not going to do it. It's going to be policy to practice. How do we take the policy here and how do we translate that to practice on multiple levels, different tiers, right? Because mental health crisis, like you said earlier, it is not mental health treatment, right? Crisis is the end. So we're taking a tier system. How to prevent that? It got to the point where any student that came on campus, it became a norm to introduce them to the counselors on campus. In fact, they thought you were quote unquote crazy if you didn't go see a therapist. They said, you got to be crazy not to see a therapist. And the first thing they do is introduce their friends to me and my colleagues. I'm like, this is a therapist. He's not here to therapize you, right? I'm here to figure out what's getting in the way of your credit recovery and what's getting in the way of your functioning in life. Destigmatizing mental health. Because really, by the time someone comes to me and says, I got an issue, it's late. It's already late in the game. And mental health is the smoke. The fire is everything that contributes to that, right? It was named earlier. We got to name entertainment, a struggling economy, people wanting to find meaning behind their work. It's not enough. We see people suffering already, working hard day in, day out, and still can't buy a home because the housing market is up in the air. Student loans are unpayable. It's hard to get a job because now everyone who has skills, and I'm in college, is now competing for the same job I want. While the cost of the housing is going up and the cost of food is going up. 1 in 5 people in Hayward, 1 in 5 families in Hayward is actually food insecure. we want to address anxiety, depression. We got to address the fact that they can't eat. I mean, if I couldn't eat and I couldn't feed my kids, I'd be depressed too. And we know also the data has shown time and time again, every time there's an economic recession or economic crash with recession, pornography and drinking go up. And then following that, child abuse goes up. It's not that child abuse goes up 2 years later. It's that people are reporting it 2 years later. It's happening. What happens when you have someone who's depressed, unemployed, at home with the kids now during summer, frustrated, they can't get a job, hurt people. They don't want to hurt people. They don't wake up and say, I want to hit my kid. But when you're depressed and you're upset, what are you going to do when they're loud and they won't stop talking while you're trying to go on a phone interview on Zoom?
What if they're in a power trip though?
Well, that brings up a whole different issue of things that need to be addressed, right? We learn patterns of behavior. If someone's in a power trip, power by definition is the ability to influence. So if they're in a power trip and they need this strong sense of needing to influence something, where does that come from, right? One of the things that we talk about in treating substance use, because usually substance use, and you can see this in the data, and Sang knows this, and anyone else who knows ACEs, adverse childhood experiences, if you're familiar with ACEs, look it up. The more adverse childhood experiences you have, the higher the risk of having a mental health or substance use disorder, as well as physiological symptoms such as, CPOD, right? Diabetes. You're at higher risk for health issues with higher incidence of adverse childhood experiences. So people who have power trips usually come from places of pain anyways, because hurt people are going to hurt people. They're going to replicate the behavior. What are we doing differently on campus that gives people different strategies to break that cycle?
Yeah, because I feel like you're talking about NVC and people having an issue with the way needs are met. I think there are some people who they don't want other people to even like have the need, like they want to sort of deprive other people. So maybe that's stemming from their own, yeah.
Because their need for power is the same. The strategy to meet that power is the issue, right? The need for power, the need for influence is the same. It's how they get it done that we have issues with. And maybe that's all they know. Remember that world, that third realm we talk about, the things that you're unaware about. If you're raised in a household where, violence was the norm, especially in your formative years, birth to, 5, I'd say birth to about 8, you're learning patterns of behavior and communication styles that look like and are defined as love, because this is what your family is. Your family's supposed to love you, and love looks like dad and mom fighting all the time and withholding food from me when I do something bad. It becomes a power struggle, right? And that's learned behavior. They're not aware of what positive things look like. And so we see this also in treatment in college students, that some college students that will, for the first time, acknowledge and find out, acknowledge and realize that they need to get treatment and they need help. They go to the health clinic, or they see a therapist or an academic counselor or any counselor, and they don't trust them, especially someone that wants to help them, right? But they do trust a substance because it makes you feel immediate resolve. But a person, how do I trust you when I couldn't even trust my own family? You're paid to be here. I got that a lot working in alternative education. You're paid to work with me. You're paid to care. My own family doesn't care about me. In the Bay Area where I live, volunteering mental health services is incredibly hard to find. Yes, that's everywhere. It is actually a 30 to 35% vacancy in traditional mental health services, right? And so, I'm glad that Sang's on this call, and anyone else from like Las Positas, and I know other schools are doing it, but creating a tier system. Berkeley City College is doing it, where they have community health workers, mental health ambassadors, and system navigators to create a tier system into mental health. That mental health is, by the time you see a therapist, like I said, it's too late. But how do I get it so I can get housing, other services, right, and supports before I have a mental health crisis, right? For college students, yeah, and the general public, yeah, like I said, there's a shortage. We want to promote mental health and asking for help, so we have to redefine what mental health is again. It is health. So how do we take a more holistic approach to address the other areas of life so that your stressors are going down? right? And when those stressors go down, your need for substances, alleviation, they may diminish, especially if your tools go up. Okay, and I'll talk a little bit about that. When a stressor becomes a threat and how you address that. But we don't have a place to send people where they won't get turned away. Yes, are there virtual services we can promote? There are a lot, and those are usually fee for services now. Those who have Kaiser are fortunate, unfortunate at the same time. Kaiser's a beast I work for. Kaiser has a lot to go on, a lot to do to improve, and I may get fired for that. It's okay. And they're at this point now because of California's law with mental health parity. They realize they can't meet the service, so they're now contracting with outside providers. So if you have Kaiser insurance, call your Kaiser department, and they'll probably authorize you to get outside therapy with a provider, which they pay fully because it's our fault we don't have enough staff. So we pay for it. Anything in office has a copay. Anything virtual doesn't. So you don't have to pay a copay if it's virtual. And most of our providers are virtual, right? So you can get authorized for like 12 months of therapy, as many times as you want within 12 months. It's between you and your therapist. So access is also increasing, right? And it's still hard because people don't know that. It's outside their awareness. So how do we create a college structure, again, that has a tier system, right? It's like, it comes back to people's usage. If people aren't aware of other ways they can still meet the need, they're going to engage in that strategy. Right? SAMHSA resources to find local services are great. Psychology Today, Access. Every county has an access line, right? It has a line in which Medicaid or Medi-Cal is taken in California, Medicaid across the state. And you can also use that line to tap into places that take other insurances. Because I know some states, Medicaid is extremely hard to get, like Georgia. Unless you're a kid or unless you're severely disabled, you're not getting Medicaid, even with a mental health disorder, right? Unless you have a doctor's note. So, definitely tap into those services. But thank you, Kim, for sharing that. And it's important for us to start mapping these things, mapping it and building it into the college culture where the resources are available. But we won't know to map if we don't ask those questions. Right? And other resources, and it starts with the people. Ask your students. And it's going to be hard because of I'd say all of the surveys you give are voluntary, right? So the students that are willing to talk about it, who don't have shame or guilt around it, are the ones that are going to share. And so a lot of the information you're getting is going to be relegated to those that are willing and open to talk about it, which makes us miss the people that aren't willing to talk about it, because we also need strategies for them. Okay. Does anybody have questions as we go? So I want to also share, as people come with questions, I'll be watching also chat, and I'm watching if anyone comes off mute, some strategies that you can introduce into your health center or into your campus. Starting with the first one is just asking the right questions, right? Asking more questions that think outside of the policies and boxes we have. For instance, I talked to Kim about this. If we want to change obesity in America, what can we do? The first thing that comes to my mind is we could just raise the index. If I raise the index, no one's obese. Simple, address the issue, job done. Give me a word for that, right? But is it really changing obesity that we're trying to get to, or is it actually creating healthier lifestyles? That's the question we're going to ask. So instead of trying to ask ourselves, how do we reduce obesity? How do we create healthier lifestyles that may reduce obesity? Because there's also other factors that contribute to obesity. But a healthier lifestyle will get to some of it. And we don't have to fib with the index. So asking ourselves, how do we create healthier campuses, one that address wellness and health? What does health look like? We have to define that explicitly, right? Leave nothing to guessing. So include mental health into health. Talk about the physiological symptoms. The pain scale, for instance, drop that. There's a military pain scale that people use, and it actually talks about physiological symptoms. So anyone who's a medical practitioner will know when you ask someone, what's your pain 0 to 10? Someone could be on their phone texting, I'm a 10. That's not a 10. 10 is killing over, right? Killing over, heaving, and wanting to dissociate. Right? You're about to pass out because you're in pain. That's a 10, right? Change the scales in which we ask the questions. The GAD-7 is one of them. It's great to ask that. Maybe ask the Bex or Burns inventory. for depression and anxiety because they cover physiological symptoms. Right? Ask it as a supplement, add it. So you do the GAD-7 and then you define it and say, I'm going to ask you the Becks and Burns inventory to explore depression, anxiety, and how that shows up in you. Because once you can name it, you can tame it. And they're like, oh yeah, I'm not anxious. I don't think, I don't feel, but all these other physiological symptoms. Do you have Crohn's disease? Because that's what it looks like. Either you have Crohn's or that's anxiety. Like, what is going on with your intestinal system, right? And I also see in chat, when I was in college, a lot of people who did these substances were aware of the stigma and solo use and therefore tried to recruit other. Yeah, they do that. You recruit others so you're not doing it alone. And it's also terrifying alone. When it's a setting drug and you're smoking alone, it's really bad. And also you find that you're going to see this behavior. Ask them, have you ever cut out friends or do you have a select group of people that you smoke with? Why? Because there are some friends that just ruin your trip. And that's a starting conversation. If they ruined your buzz, ruined your trip, you got to ask them, okay, what about that trip that were you trying to get? What does that alleviate? What does it make you feel? What do you achieve from that? And that's how you start naming it. Oh, so it's not about the smoking, it's about the anxiety. And they just caused your anxiety. Okay, right? Which comes to the second strategy that I'm going to introduce, motivational interviewing. How many people have heard of motivational interviewing? Yes, it's great. It's used for substance use disorder. And it's a way to get people to admit to their usage without having them get to admit it, right? Because most people don't enter treatment because they want to. Most people don't. They do it because there's some other conflict or some other legal issue or relational issue that drives them to. I'm here because my wife made me. You have a drinking problem? No, I don't have a drinking problem. I have a problem with my wife yelling at me. Why does she yell at you? Because I drink. Okay. So let's not talk about the drinking problem. Let's talk about why you guys are arguing. So you're arguing about the drinking. What can you do that's going to reduce your drinking or help it so that your wife can understand your drinking so she's not yelling at you? Asking those questions puts people in a place where they have to come up and develop their own insight and realize, oh, snaps, maybe I'm drinking because I need this, this, and this. Okay, I need help with that. Because telling someone that they have a problem is not going to be helpful. Helping them realize it. Helping them realize what they're doing, what strategy they're using, what need they're meeting is going to help them derive their treatment, right? Now that our nation is talking more about the vitality of mental health support, do you think our society will reach a point where mental health is consistently listed as an affordable option alongside mental? No. We actually had an option in California about 4 years ago, 4 or 5. My timeline's been thrown off since COVID, where we had legislation. Usually what happens is insurance is renegotiated and redefined, and Medicaid or Medi-Cal is renegotiated and redefined, right? And what health it looks like. So they're usually scattered, right? This will happen on this year. This will happen this year. Several years ago, they happened at the same time, meaning that we could have redefined what health and insurance look like. And we missed it. If we redefined mental health as part of health, housing as part of health, it would force Medi-Cal and insurance to cover it. But we missed it. So now there's still 2 different definitions, 2 different conversations. And this is a larger conversation for policymakers when we're looking at Medi-Cal, Medicaid, which covers primarily youth, but also youth up to the age of 26, which is our college students, right? And that there's what we call PPE and CPE, how it's funded. When the federal government funds it, it's a 1-to-1 ratio. When it's private money or other foundations that contribute, when we track it, the federal government is entitled to match it dollar for dollar. And in the state of California, for children's services, we have billions of dollars in services that we're not tracking that we can throw at the federal government and say, you need to match it dollar for dollar. If we just did that, we'd have more funding for these services. The other issue that comes up is just because we have funding for the services brought up earlier, we don't have the personnel. So we have to redefine what that looks like. It's not just social workers, therapists, psychologists, but it's community health workers that are educating people. So they understand that, oh, the substance is an issue. It's what I'm using it for is the issue, right? Drinking wasn't an issue. It's when I drink alone to cope. Now it's uncontrollable. Smoking may not be the issue. And I will reduce smoking if I find other ways to alleviate my stress. And I may not use it anymore because once I realize the financial impact it has on me, I'm gonna reduce it anyways, because I could be spending that on video games, food, my degree, job, gas, insurance, right? It's helping people educate on the impact it has financially on their lives and what they're using it for. Navigating the system, right? How do we navigate the system? Create a tier system. Public health people in here, you all know the analogy, right? 3 sisters are going down by the river. First sister, they all see babies drowning. The first sister says, I'm gonna save the babies, jumps in and starts saving the babies. That's crisis intervention. Second sister runs up the river a little bit, jumps in and starts teaching the babies how to swim, right? That's early intervention and prevention, right? And the earliest prevention is the third sister who runs upstream and tries to figure out why the baby's jumping in the first place. How are they in the river? That's where policies come in, because policies will drive funding, and funding drives policies, which drives practices, drives systems and programs. We need all 3 at the same time. You have to create a tier system. All right. And it's all health related. The issues you see in your community, in your campuses, are directly reflected upon the community's inability to meet those needs. Whether it's joblessness, houselessness, food insecurity, those things that all contribute to mental health, and the substances that help us numb and forget about it, that also contribute to her problems. Because if I smoke, I can't go to work because I'm not forgetting my task, but at least I forgot my problems right then and there. Right? Anybody have any final questions as I wrap up? We have 3 minutes left. I hope this gave some context as we enter into tomorrow, especially when we look at policies and systems. And we discuss, I hope many of you come back for tomorrow, when we discuss and explore how do we create these systems on the individual student level and on a campus level, culturally, and across California as a large collective movement. Because when we create movement together, more change is bound to happen, right? And it creates a culture. All right. Watching, cool. No questions? All right, I look forward to seeing you all tomorrow, especially when we explore the quadrants of change and how we move this holistic practice into the policies we can create with each other.
Thank you so much, Yang. And I'm just echoing several comments in the chat box about the discussion being awesome. And thank you so much for sharing your wisdom, and also for the incredible work that you are doing with youth and young adults. We need more people like you providing services and care to young people. Before we transition over to the next session, I did just want to note, because I think that this is incredibly important to really uncover. And you mentioned the fact that as a society, we have been criminalizing substance use. There was just an article about this morning in the New York Times about the fact that we have to really shift away from criminalizing individuals who are using substances, both from a law enforcement side, but our own criminalization of them through the language that we use to identify individuals who are using substances, really shift this approach of doing so. And then also looking at mental health and mental health treatment and crisis. And I just want to note that this isn't, what I'm sharing is not going to impact colleges and universities, but I do, going back to the reality that a lot of young people who are going into college and university spaces are existing in high schools right now. And unfortunately, our state laws are currently cause harm to young people in our K-12 space. Interestingly, our Tobacco 21 law purposely removed youth possession, use, and purchase language for T21. And so if you're in a community and you're under the age of 21 and you are found to be in possession or use or purchasing a tobacco product in California, you cannot be criminalized under state law. Local jurisdictions, unfortunately, we are seeing some moving in that direction. But our K-12 law, which was passed, or smoke and tobacco free K-12 law, which was passed the exact same year in the very same session as our T21 law, does include language that criminalizes young people for possession and use of tobacco and other substances on K-12 campuses. There is currently active legislation. It's Assembly Bill 599. It's out of legislator, Assembly Member Ward in San Diego. If it were to be passed, it would decriminalize tobacco use in K-12 spaces, which means that a young person found to be vaping or using tobacco on a high school or middle school campus would not go through suspension or detention for the first time that they would have to go through intervention. And the focus is on trying to get K-12 spaces to practice more intervention, motivational interviewing, referral, all of those pieces. It's very important legislation. I do want to note, though, that unfortunately, when it was originally written, it was written to decriminalize all substance use in K-12 schools, and the language has been altered to only focus on tobacco. I don't know the history, but again, I think that shows some of the disparities that exist in our public health laws and policies, and the fact that we legalize marijuana to decriminalize marijuana use, and yet we are still purposely criminalizing marijuana use in schools, but trying to decriminalize tobacco use. So a lot of work to do. I think it's really important that we consider all of these things as we are working on policies, which is what our talk is going to be about tomorrow. But I am now excited to really transition this over and hear what we can do. I know our team at CYN participated in the Stanford conference last week. It was an excellent conference, and it was really focused on high school, middle school spaces. And within that conversation, we had a debrief, and a lot of us were sharing our thoughts. And it was a very heavy conversation of like, oh, everything we're hearing is hard and sad, and our systems are broken, and how do we address this, and what do we do? And I'm really grateful for my colleague Caitlin, who said it's really heavy, but what can we do, and what did we take away, and what's the good thing? And what we loved is a good thing is that we're having these conversations, that we see it, and that we are collectively wanting to do something to address this reality that we are living in. And so with that, I'm really excited to turn it over to Stephanie Lake, and Stephanie's going to share what this looks like at the university that she works with at UC Davis. Stephanie is the Alcohol, Tobacco, and Other Drugs Intervention Service Coordinator at UC Davis. And what we're going to do is I am going to just have a facilitated conversation with Stephanie. I have a bunch of questions. These are all things that I really want to know from Stephanie, so I've already prepared these. With that said, if you have questions for Stephanie, just drop those in the chat or raise your hand, ask those questions of Stephanie as well. This is really meant to be an organic conversation, so don't hesitate in asking the questions yourself. Just let us know if you have them. Before I turn it over with the first question, I do also just want to acknowledge to Stephanie and to the community in UC Davis, which is very close to my heart as it is my alma mater, but we are with you all in thought as the community is going through a very, very difficult time right now, and hoping that safety and a sense of calm and peace returns to your community and to your student body soon. So please know that you all are with us in thought. So with that, I'm going to spotlight you, Stephanie, so we can see you. But again, if the conversation gets really active, we can turn it over and have other faces on the screen. But before we start, Stephanie, can you please just start by sharing more about your role at UC Davis and the work that you do with students?
Sure. So I have been at Davis for 23 years. I started in 1999, which is kind of like, holy crap, it's been here a while. So I've seen a lot. And I really wanted to appreciate because like, I think you and I are like soulmates, because I was like, everything you were saying, I was like, oh, this is what I do. So basically my job is to do all of the substance abuse counseling, all of the intervention services. I use motivational interviewing. I use basics. I do all the tobacco cessation. I do all the vaping cessation. We have a collegiate recovery program here. And I am the only substance abuse counselor for 41,000 students. So I just have to keep saying that because I've been asking for years for support. And it's like, oh, and for years, it was very much like Stephanie over here doing substance abuse and everyone else over here doing mental health. And it's only been, I would say, in the last 5 years that we're really now putting substance abuse and mental health together, which I'm thrilled about. I actually do basics. I do motivational interviewing. I am also certified in comprehensive resource model, which is a somatic-based therapy. I'm also one of the few, I'm the only counselor on campus that actually does not have a session limit. So I can see my students as long as they need to. And for some of them, it's the entire 5 years that they are here, because I like to use the iceberg theory. Like when they come in, the substance abuse is up here and the tobacco and the marijuana is up here. And then once I take that away, the anxiety and the depression starts to come up. And so I have to do, and a lot of trauma. So I get to work with all of those. And I love our collegiate recovery program. I'm also a harm reductionist. So some students actually are not at the point of quitting completely, but it might be like, well, my marijuana is causing me a lot of anxiety, but I still can drink. Okay, so let's see where, so I do a lot of, that's where the motivational interview comes in. It's like, I meet them where they're at and try to see where they want to go. And harm reduction is actually an amazing way of getting from maybe cutting it back to abstinence. So I think a lot of people forget that harm reduction can lead to abstinence. That's a little bit about what I do. I work with both the undergraduate, the graduate, the vet schools, and the medical students if I need to. So I work with all of them. And I can say it's been interesting in the last 5 years. I would say I've been working more and more with graduate students, which doesn't surprise me, than the undergrads. But I will definitely say since the pandemic, the mental health services are amazingly increasing. And my caseload has tripled. And it's me. And we also had the same thing with like, we don't have enough counselors. Like we've had a vacancy here in our counseling center for 5 years working with the immunosuppressed communities that's still vacant because we want to hire the right person, but we just can't find it. So there's definitely that. We do have, and the Davis community, unfortunately, most of our counselors are book solid. And there aren't many in the community that focus specifically on substance abuse or tobacco cessation. So that's one of the reasons I feel very fortunate that I get to meet with students as long as they need to meet with me.
Thanks, Stephanie. So I have a memory from years ago, pre-pandemic, when vaping kind of started to take off. And I was at UC Davis giving a talk on student vaping and things that we were seeing. And I remember very specifically a conversation that you and I were having, and you were telling me about just the reality that you had in not only treating the nicotine vaping, but also marijuana, and yes, seeing that you were having to actually put students into residential treatment because yes, of the levels of addiction. And that was 5 years ago. We would love to know from you, just because you've been there and experienced all of these changes for 23 years, can you talk about what you are seeing today and what changes look like specifically over the last 5 years since the start of the vaping epidemic?
One of the things I would definitely say, and I really want to appreciate everyone talking about the language, because if I use the word e-cigarettes, they don't know what I'm talking about. So I have to use the puff bars, the Juuls. They're not even using Juuls really anymore. It's more like puff bars and stizzies. And we actually have one of our marijuana dispensaries is actually named Stizzy here in Davis. So I think that's kind of more ironically funny. They're definitely doing a lot more of the marijuana and the tobacco products together, either with blunts or mobiles or spliffs. The mobile and the spliffs is where they actually take the tobacco and put it into the bowl and smoke it. We're seeing a lot more psychotic breaks because of that. We're seeing a lot more anxiety and depression. There's a ton of misinformation where the students are like, oh, it's not anxiety producing, it helps my anxiety. So I'm doing a ton of information, just education, because the good news is when they're caught on campus for smoking anything, because we are smoking tobacco free, they're sent to me. They're not in trouble. We also have our Aggies Act where they can actually just have a letter on their file. So they're not on probation, but they come to me. I'm doing a lot of education around this is how the cannabis affects you. It's also really important that we use cannabis instead of marijuana. Marijuana is a very derogatory term. It was made actually for a lot of the African-American community. So I worked very hard with my language to say cannabis. Now, if they're using marijuana, I'm going to try to educate them too about it's cannabis. And also just that, like when I started, you know, when I was in college, yeah, it was 3%. Here in Davis, the lowest you can find is 20. So Kim, you may want to change it because the lowest now is 20%. It's no longer 15, it's now 20. For most of the cannabis products. Now the edibles are usually 5 to 10%. And I'm also doing a ton of information around just how it affects them physically, emotionally. And I think it was interesting on when you were talking about the fact of a lot of them are using it alone to help them cope because of the pandemic. A lot of them actually stopped during the pandemic. So it was kind of this dichotomy of either a lot of people decided to get clean and sober, but then a lot more got really depressed. And especially what we're finding is a lot of our sophomores now that when we started last year, we called them, actually, we had 2 years of freshmen because they were in the pandemic. So they didn't have, so there's a lot of social anxiety too around the fact that they don't have a community. And being alone, that's what they did, is they either smoke or drank or did all three. So that's the other thing I'm seeing is a lot more of them using a lot of other substances as well, just to cope, because they haven't learned how to cope because they're using either this, which is their phone, or they're on a Zoom and they hate Zoom. I was actually thrilled once we were able to come back in person. I'm only in the office, I should say I'm in the office 3 days a week and I'm only at home 2 days a week. And I really enjoy that because there's such a connection when you're in the office with someone than when you're on Zoom. Like I literally had someone yesterday that I've been meeting with for over a year and I'm like, you're vaping in a session. No. And I'd never seen him vape before. And he's like, oh, I've been vaping for a year. And I was like, wait a minute. So again, you know, I have to say these rules like, no, you cannot be vaping in a counseling session with me. So I'm seeing a lot more of just this idea of, oh, it's just natural. No, it's not. But I actually and I do a lot of humor with him. I was like, what? No. But I'm definitely seeing a lot. And there have been, I would say in the last 5 years, I have put probably about 8 people into residential treatment where marijuana is the #1 drug of choice. And I think that's an important statistic because, again, the students are like, oh, it's just a plant. And what I say is, well, poison ivy is a plant. I'm not going to, and they're like, oh, I never thought of it that way. So when I use some of the humor of just because it's a plant doesn't mean I'm going to smoke it. They kind of like that. There are definitely a lot of things around. We have patches, we have lozenges, we have nicotine gums, we have Chantix and Wellbutrin, which we use. One of the things that I am finding, if they are trying to quit vaping, I am definitely starting them on the 21 milligram patches, and it might even be 2. I am definitely starting them on the 4 milligram gum, and it's usually the way it works. With cigarettes, it was like 1 month on 21, then you go down to 14, then you go down to 7. And with the when they're vaping, I'm going to give them at least 2 months on the 21 milligram patches because there's so much more nicotine. And I saw someone put opiate and cocaine from, yes, that's one of the things that I will say a lot of times when people are talking about that. I'm like, the only thing that actually doesn't come from a plant is meth. And that doesn't mean I want you to use meth, because they're like, oh, I'm like, no, I do not want you to use meth. And I'm even talking about Adderall sometimes, because a lot of them are sometimes, they'll also be like, oh, well, I'll use the Adderall to help me come off of the vaping. And I'm like, no. I mean, if you're prescribed Adderall, that's one thing. But again, I work very, very closely with our psychiatrist. I work very closely with our medical doctors. We're very much of a team here because the amount of mental health, I would say, has probably quadrupled. And I can just go on and talk about this one topic for like hours. So I'm trying to be cognizant because I'm sure there are other questions.
Yeah, so I think one of the challenges that we've seen, and I've definitely noticed this specific to college treatment and college tobacco treatment, is that we have our best practices for how to treat nicotine dependency. And the biggest, not the big, there are many struggles to treating dependency, but a big struggle that we have with young adults is that oftentimes they may recognize they want to quit, but they won't utilize services.
Yeah.
And in the past, one of the things we've known is also that students might be hesitant to the recommended best practices of combined therapy, of use of an NRT and the counseling. So can you talk about what services you currently offer right now and what students are open to using today, recognizing earlier onset and higher levels of addiction?
So again, when they come in and they meet with me, I have a little questionnaire that they fill out before they even meet with me, so I know like what they're using. And then I went through the Mayo Clinic training probably 2012. I have it in front of me, which is probably one of the best trainings to become a tobacco treatment specialist that I've ever been through. Highly recommend if you've never done it. It's expensive, but it's well worth it. And they gave me some really good best practices, which I still use today. So one of the first things I ask them is what brings them in? What do they want? Do they want to cut back? Do they want to quit? And then I'll talk about what are your barriers to quitting? What are your strategies to quitting? What social supports do you have, if any? Because some of them don't have any. And then I'm going to talk about, okay, what follow-ups do you need? And then I will offer the nicotine replacement therapies that we offer. If they want the Chantix or the Wellbutrin, they have to actually go through their doctors. However, the doctors here want them to meet with me first so I can offer the NRTs before the actual medication. It's just a doctor thing. I'm like, fine, whatever. And then we give, like I said, we will give at least 1 month free, but then their insurance will kick in for another month. So we give at least 2 to 3 months free. And then I also offer them follow-up because I'm like, you cannot do this alone. So in 2 weeks, and I give them the 2 weeks because I'm hoping that they're going to quit pretty quickly. I had one student that met with me in January and was like, I want to quit by the time I graduate in June. I'm like, nope, that's too long. No, that's not going to work. He's like, what? I'm like, not going to work. I even just said that. And he was like, I said, so what are you willing to do? And he's like, okay, maybe. He was willing to cut it down and he was going to meet with me in a month. And then by that month, he'd actually quit. And then we do follow-ups. So my follow-ups are, our initial sessions are normal 50-minute sessions because I never know what I'm going to get. And I'm doing a lot of motivational interviewing. I'm also asking them about other drug use. I'm also asking them about pornography as well. And I just make it part of my general everyday things because what I'm finding is with marijuana and tobacco, there's a lot of pornography. It doesn't seem to be more with the alcohol. It's very, for whatever reason, it's the marijuana and the tobacco. And as that goes down, the pornography goes down. I talk a lot about making sure that as their tobacco and or marijuana goes down, that their drinking doesn't go up. I talk about how if they are going to take the gum, on the package, it says you can't drink while you're on the gum. I tell them you can absolutely drink while you're on the gum. It's just not going to be as effective, but I would much rather than be using the gum and going out and not smoking or vaping than not. I also talk about, following up, and then my follow-up sessions, depending on what's going on with them, are usually a half an hour. And the reason I say depending on what's going on is the fact that for some of them, if they've got a lot of trauma going on and they're also doing the substance abuse, but they're coming in the back door for the tobacco, I'm going to actually work on all of that as well. So if there's more stuff going on mental health wise, I'll do a follow-up for an actual hour. And for a lot of students, when they come in for the tobacco, I actually end up doing I do the CRM with them. I do the trauma therapy because there's actually some trauma, which is why they're smoking. And again, they can meet with me again as long as they need to. And for a lot of students, what's also really nice is if they relapse, so they've been like off the nicotine for a year. And then they come back. I just had this happen 2 weeks ago. I hadn't seen someone in a year and he's like, I'm back. I'm about to graduate. I've got my master's and I relapsed. I'm like, okay. He's like, can I get the gum again? I'm like, absolutely. He's like, I bought a pack. I'm like, oh, I wish you hadn't bought a pack because that's $60. I could have saved you, but they can come back as well. So that's the other nice thing is like, again, they can come and go as they need to. And for a lot of them, one of the best things, I love the story, is I had a student that actually, she quit smoking. She was smoking cigarettes. She quit by buying herself a $3,000 bike. And then she basically was like, she paid off the bike. She stayed quit. She got married. Her husband was a social smoker. She was a total addicted smoker. And she's like, now I'm back to smoking again. So she came back in and we started working on it again, and she was able to quit again. So she used some of the similar tools. So again, it's one of those things where I work a lot on what's the underlying causes. And so again, for some, they meet with me for months. For some, it's a couple months. For some, again, it's been years. It just depends. But again, I'm also making sure that when they come in, I don't want to say just, because I had someone come in the other day that said, oh, I'm just here for tobacco. Cool. Where's your alcohol use at? Well, I kind of drink a little. What's a little? And then I'll ask them. And I always take any other drugs. And I just make it very like, as if I'm asking like, what's the color of the sky? So I think that's the important thing is like, and again, I'm also asking about other things. I talk about shopping. I talk about, gambling. I talk about all of it so that again, when they're cutting down, and everyone has always said, oh, I thought you'd shame me. I don't shame anyone. And I also talk a lot about a slip and a relapse. I always talk about that. A slip is like, okay, say you're quitting tomorrow and you end up going out this weekend. And with everything going on in Davis right now, there's a lot. We've had, the stabbings and everything. My guess is the substance abuse is going to be really high in the next couple of weeks because people are scared. So I said, you may go out and you may end up having a cigarette. That's a slip. But if you end up having and you smoke until you meet with me again, that's a relapse. Do I want either one to happen? No. I would much rather you have a slip versus a relapse. So again, and I'm like, and if it happens, we'll talk about why and how. And I also make sure to talk about one of the best things that I do is like, what do you like to do for fun? And especially if it's the marijuana or the cannabis, they don't have a lot. They're like, everything I do with cannabis. I'm like, okay, what about just crocheting without being high? And they're like, what? So I do that. And same with the nicotine. It's like and I did this yesterday with a client. I was like, the cravings last 10 to 15 minutes. Do something for 10 to 15 minutes. Like, I never thought about that. I said, but do not set an alarm. Because if you set an alarm, you're waiting for that and your brain's not going to actually be reorganizing itself. So I make sure to do those types of things. I give them something to do instead. I'm also asking them, like, what are the times? And so I also talk a lot about the sleep. And one of the things I love about the basic survey is it's a statistically significant survey that shows with cannabis and sleep how it affects your sleep. So I can show them and be like, hey, this is how it affects your sleep. And like, oh, crap. Like, can I take it? I'm like, of course you can take it. This is your survey, because a lot of it is showing the other students that they're actually truthful, because they're like, I thought this, but everyone else was telling me I was wrong. I was like, no. So I let them take it and I give them tools. I also give them the quit line a lot of times. I'm like, I'm only here, Monday through Friday, 9 to 5. If something happens, call the quit line. If you need more products or you need some more smoking cessation that I can't give you, I can give them that too.
I love that perspective, Stephanie. And I think sometimes we think of treatment as one thing versus all of the things.
Right.
And how can we make sure that you can get support wherever you're at, whenever it is, whatever it looks like, and that it doesn't have to be just this, or this. So I think that is a really great reminder of that. So I think, I want to shift just a tiny bit. You had mentioned students are coming to you. You are one human for 41,000 people on campus to do all of this. What happens before they get to you, both from, what does screening look like from the student wellness side, but also what does screening look like to get students from counseling, mental health counseling over to you?
We have a couple things. And one of the things that I'm really, really excited about is any student that walks into the building I'll start with the medical side, because I'm actually in the medical side. They are asked about their tobacco use, and they're asked about their cannabis use, and they're asked about their alcohol use. And it's before they get in. And if they say something about their tobacco use or their nicotine, whatever, they will then be asked, oh, are you interested in possibly meeting with somebody who can help you with that? And if the answer is yes, then they'll CC me on the note, and then I'll reach out to them. On the counseling center side, it's very similar. We have I can never remember what it's called, but it's the thing, all the UCs have to fill it out. But we got really innovative last year where we actually brought it all the way to the UCs to see if they wanted to take all these cannabis questions, and the UCs didn't want it, but we're still going to do it. So what happens now is We just changed this quarter, so I'm a little shaky on it. It used to be called an initial intake. It's now called something, it's now called CARS, and I can't remember what it stands for, where it's more like a 10 to 15 minute session just to see where they need to go. We also have our POD, which is our psychologist on duty. So if someone's in crisis, they can walk in anytime during the day and be seen. And then if they're talking substances, they'll either call me or healthy message me, be like, hey, can you come meet with them right now? Or they'll just put them on my schedule and CC me on the note. But with the other thing, what's nice is on the second session, they can then answer more of those questions individually in a much more greater detail about their cannabis use, about their alcohol use. And then the way they get to me through their advisors is sometimes if someone's showing up to class either high or drunk or smelling. I mean, unfortunately, a lot of the tobacco products smell great now. So they like, oh, they smell like lemons. They may be like, are you vaping? So that's how and then the advisors can call me and they can set up an appointment. We have an appointment system where you can just go online if it's just tobacco, and this is actually how some of the people get to me. If it's only a nicotine product, they can go online and make the appointment online. If it's any other products, they need to call me because I'm going to send them the basic survey because I want to know ahead of time what their usage is like so I can go over that. So what a lot of people will do if they're vaping and using the cannabis, they'll just come in for a smoking cessation appointment and then I'll send out the basics on their second appointment because I'm like, oh, you're doing the cannabis too. But I'm okay. However they get to me, I'm okay with however they get to me. But that's how they get to me. And I saw your question in the chat, my challenges. I could spend a whole session on this because I've been fighting for 12 years to get another me. I came through back when we got the mental health initiative grants 10 years ago when our CAN position, which is our community action network counselors, came through. And since then, I've been fighting to get more of me, and it drives me crazy because with all the mental health funding and all the substance abuse funding we just got, they're doing all sorts of other things and they're not funding me. I have a meeting on the end of this month just to talk about possibly getting funding just for my collegiate recovery program, but not for another me. So it's like, I have full-time funding. I've had full-time funding, but it's just me. And I keep saying, it's great that we're hiring a new trans counselor. I think that's fabulous. We have maybe 400 trans students. I see over 1,000 students, just me. And that's a rough estimate. So it's like, I would love to have another me, but I'm working on it. So yeah, I'm at a loss. I don't understand why they don't get it. I think it's super important. I did bring it up to our management team and they finally admitted that when they think substance abuse, they don't think mental health. So they're not in. So I'm trying to get management and the powers that be. I think our vice chancellor gets it, but for some reason, my medical director doesn't get it. I mean, my executive director. So I don't know. I'm just like chipping away. And the other thing is I'm doing counseling full time. So part of it is while I'm doing counseling full time, I don't have the time to go and, advocate for myself. Because I'd rather be with students, honestly. I don't play politics well.
I think you just shared a perfect example of how the systems often restrict us, both the systems and the funding, from doing the work that actually needs to be done. And I think what's interesting too, looking from a data perspective, and this is, I love that UC Davis is integrating all of the different partners into these conversations. I think the hard part, at least that I'm observing, is that even with the integration and the questions about substance use and the referral to you, is that there is only one of you, which is problematic. But I do want to know, again, some of the recent data from the Achanacha survey, which I found to be fascinating, was that when the students were asked about if they would seek help from a mental health provider on campus if something was bothering them, 79% of students said that they would. What's interesting about that is that most students who participated in the survey and had used either tobacco or cannabis said that they had not made a quit attempt in the last 3 months. It was even lower for cannabis use. And so if you think of integrating those services, if you think of somebody who says, yes, I will seek support for my mental health, if they're being asked that question and then referred out, that in itself is critical. But then again, how do we get more people who can be referred to? There's a lack of support in that space.
Well, and I also think there's just even though I've been on the campus for 23 years, I also think there's a lack of knowing that I'm here. Because I've had a lot of people say, oh, I didn't even know you were here until my friend went and saw you. So I don't, and again, I work very closely with our health education department. They're amazing. I love them. So, with Rayanne and Nora and everybody over there and everyone else and Chantal and everyone. So we're working really hard to also just continue to update. But again, it's like we've got a social media presence, we've got our Aggies for Recovery, we have the mental health initiative. I'm also working really closely with our underground scholars, which is our formerly incarcerated students. But I think there's only, and I'm not a good marketing person, like that's not my area at all. So that's where I need some help, is like, someone market me, let people know about me. However, there's this other part of me that wants to protect myself because I'm busy enough as it is. It's like, if you build it, they will come. I'm already like last winter, I was booked out 3 weeks. Again, it was like that, a lot of our counselors are booked out months in advance, and that doesn't work when someone's in crisis and trying to quit. I need to meet with them weekly to help them go through the support that they need. 3 weeks does not work. It causes a lot more relapses. So, again, it's like, I know my colleagues and I, like, we'll put people on our lunches sometimes, but it's also about the work-life balance of making sure that I'm not overworking. But I think, so it's kind of like, I would love more people to know about me. And maybe someone once said to me, don't do your job so well. And I'm like, no, I don't do my job, someone dies. So I'm sorry, I'm not willing to do that. I'm not willing to put, and that's actually what we had a staff meeting this morning about the stabbings that's going on. And one of the things that I said is, I think we're also going to need to really look at, students are scared, rightfully so. We're scared. We went to evening classes are now all remote. The substance use is going to go up. The vaping may go up, because what do they do when they're stressed and they don't have coping skills? It's really easy to numb out. I mean, cannabis is the best way in the world to numb out. So I think and a lot of students feel very, very helpless. And so sometimes, again, substances can actually make them feel powerful, depending on the substance they're using. So and I'm a little worried about the vigilante. We had someone yesterday walking around with a bow and arrow. I'm like, no, please put the bow and arrow away. So again, it's a very interesting time right now. So I
just want to close out with this last question, and really appreciate everything that you've shared. As much as you have limited resources, I want to note that unfortunately, we know that oftentimes our community colleges, sometimes our CSUs have even fewer resources to be able to provide this care to students. So can you just share some advice or thoughts that you have for these campuses on what are some things that they can do, or for community partners, how can we be supporting our colleges to ensure that students can get some support if they need it, if they share that on their campus?
Sure. One of the big things that we've done is we put together quick kits where we put a little brochure from the American Lung Association about what happens when you smoke, when you quit. Really quickly, we put the actual quit smoke line in a thing. We put my card, and if you don't have someone at your campus, we put some big red gum, because we know cinnamon gum actually helps with cravings. And then we just give, so we just gave some resources. And we actually, at one point, we ran out of money, but we were going to put like a fidget spinner in it, but we didn't have enough money for that. So just something little that they could play with, because a lot of times it's just having something in their hand. So having quick kits is a great resource. Also just being able to call on the other, you know, if maybe, so I know like what we've done is like if we run out of nicotine replacement packages, we can call the quit line. I've even told students to call the quit line a lot. The quit line is one of the best things. Call the American Lung Association or the American Heart Association. They have a real, let me see which one it is. One moment, I'm gonna grab it. It's the American Cancer Society. This is what we use. It's called When You Quit. Whoops, I'm just wrong way. So that's what and that's free. You can get as many of these as you want. So that's what we put in their quit kits is When You Quit, because it's just a really nice thing. We also have some specifically for the LGBT community. So we have packets as well, because sometimes it's nice to include the LGBT community in a quit kit. So they don't feel left out, because a lot of times they feel very us and them, and we're trying to make it more. So I would say get things like that. And I would also just say again, yeah, the quit kits is the best thing.
Okay, thank you. Thank you so much. We do have a question, so I want to open it up before we close this out. Go ahead.
Hi there, I'm Kathy. I'm a registered nurse over at San Jose City College, so community college. I usually see the students for smoking cessation, and originally back when I started back around 2015, 16, I did the Breathe at their program, which was designed to be a group program. Our students tend to not like to meet in groups. They tend to like to meet one-on-one, but that is the model that I use when I'm counseling, and haven't had formal tobacco counselor or substance counselor training. My question is, you know, now with, I don't see students that smoke anymore. They're all vaping, and we all know that that's kind of this age group and what's happening. And I feel like the Breathe instruction that I had years ago, you know, the motivational interview piece and the stages of change and all of that stuff is still very applicable. I just feel like I don't have a lot of resources for NRT recommendations and supporting students because of the high level of nicotine that they're getting, and, you know, the appropriateness of counseling them to maybe consider cutting back for a period of time before they elect it. So I feel like I'm a little out in the desert by myself, and would like to have some resources that I can access that can help me be a better facilitator for my students. So I'd like some input on that if you have it.
I wish I did. That's one of the things that I was saying is like with the NRTs now for vaping, just through my own, when I went through the Mayo Clinic, they were all talking about cigarettes too. And then they started talking a little bit. So I've just like, I always start with the 21 milligram patches, always, because there's so much more nicotine. I always start with the 4 milligram gums. And some of them, I will tell them, if the 21 milligram patch is not enough, put 2 on. And the way you'll know if 2 is too much is if you start to feel nauseous, you can cut the second 21 milligram patch in half. It's not going to kill you. But that's what I always start with, because there is so much more nicotine in the vapes.
Right.
Same with the lozenges and the gum. I always start with 4, and I'm like, you know, again, you might, if they're doing the gum, I can say like, you can put 2 pieces in. It's very anecdotal because I don't think there's enough information out yet that it's all still based on cigarettes. Mayo Clinic may have had something new. The last time I went to my conference was 2019, and then the funding, it was $3,000 for a week, which was great, but we just didn't have the funding.
Right, we don't
So
either.
you can check the Mayo Clinic, they may have something on it. But I don't know if anyone else has anything else, but that's what I always start with is just, and I ask, and I'm also in contact with them pretty regularly. So we have a healthy message system. So I can like, if you're having any symptoms, please healthy message me. I can walk you through like what you need to do, because yeah, if they're starting to feel nauseous, it means it's too much. If they're getting like a lot of diarrhea, it's too high, things like that. But usually what I found when they're quitting the vaping, the 21 milligram patch is what I never even looked at the 14 or the 7. And I
And
keep
before
going,
you're making that determination, are you kind of assessing the level of nicotine that they're taking in, right? Because it depends on the
Yes.
product they're using and how
Yes.
much nicotine and how often. And I mean, so there's not even really, whereas we had a visual,
Yeah.
how many cigarettes are you smoking?
Right,
How
exactly.
often are you smoking it? We don't have that anymore. So it's kind of this huge amount that's out there. And as a nurse, you know, recommending medications and things
Right.
like that, we're looking at side effects and toxicity
Right.
and all that kind of stuff, which gets me into an area that I'm not necessarily comfortable with saying, put 2 patches on.
Well, and so what I do is I'm gonna ask them, like, how much are they vaping? And 9 times out of 10, they're like, it's all day, every day. And I'm like, what are you using? And when I'm finding out that it's like the puff bar, which is 4 times higher, 14 times higher than the Juul, I'm like, okay, the Juul was 1 pack of cigarettes for a Juul. So
Right.
I'm already noticing, like, when it was the Juul, I was telling them to start with 21. So that's why I'm gonna definitely start with, I always say start with 21. If you're feeling like you still want to use it on top of that, and then again, I'm going to talk about, then you can put a second patch on, but I always start with 1. I don't necessarily say start with 2. I always say start with 1. What about females on birth control? Again, my understanding is, and if I'm wrong, Kim, you may know this better than me, it's the same with vaping as it is with cigarettes. So there's still the possibility of blood clots and everything else that can happen. So I let them know, you know, there's a possibility of blood clots and things like, same thing I would do with cigarettes, because that hasn't changed.
Yeah, and Eliza is also just noting Dr. Tong from UC Davis Medical Center. Clinically, there's a cotinine urine or blood lab to measure to get an idea of how much nicotine replacement therapy dose is needed. I did it before for a young person who said he didn't use smokeless tobacco that much, but his level was about the same as a pack a day. Okay. So that's definitely good information. I do just with the question on the birth control and also a follow-up to the question that Kathy had asked as well. The state of California Department of Public Health has recently funded the Smoking Cessation Leadership Center, which is out of UC San Francisco, to lead some more tobacco treatment work here in California to provide additional information and training to nurses, medical providers. Our hope, this is my hope. I don't know that this will happen, but my hope is that this also means that maybe we'll see some tobacco treatment specialist trainings here in California, because we don't have any in California. I think the closest one is in Colorado. So you're adding on not only the cost of the training itself, but all of the travel too. So hopefully this is something we see. Our team in the past, before the pandemic, actually used to do a full day regional training for colleges where we brought the KKIT California team, who was a pharmacotherapist, to talk about how do we treat dependency with vaping, what this looks like. We hope to have the capacity to be able to do that again in the fall. So stay tuned for that. I also want to note, and I was trying to bring it up quickly, but I can't seem to find it. In addition to the question that Heidi asked on birth control or on hormones and NRTs, this is also a really important consideration for transgender individuals as well. It's really important to understand medications and co-use and the impact of nicotine and NRTs. So our partners at We Breathe, which is a project of Health Access, has a great document on this. I'm going to try to pull that up and then I can share it up in our follow-up email as well. I do want to close out and just thank you, Stephanie, so much for the work that you do, for your comments, and for sharing with all of us. We appreciate you and everything that you shared today.